a strong pulse along the inner side of the left sternocleidomastoid muscle. The
Okay.
vein palpated by the doctor is a derivative of which of the following aortic arcs?
Okay, perfect. So who is going to answer this MCQ for me? Like, as it's a kind of revision session, so all of you guys have done this MCQ, right? So first of all, you guys have to tell me the concept of this MCQ, right? What lies, like, along the inner side of left sternocleidomastoid muscle? Yes, what do you guys think?
The common carotid artery.
Common carotid, perfect. So this vessel is derivative of which aortic arch?
Third.
Third aortic valve.
Perfect. Common carotid. So for that, you should know that it arises from third. So like you should know two things here, right? The derivative of your sixth aortic arc. What's the derivative of your sixth aortic arc?
Patent ductus arteriosus.
Okay, ductus arteriosus. Ductus arteriosus. Okay. So these two points are really important. You must know that. Like the other one are like not that high, right? So the two of one, like you guys can see that your maxillary artery associated with the trigeminal nerve, like you have some pharyngeal and aortic arches. So you should just learn this table by heart, right? It's very important. You are going to see like a lot of MCQs coming from this portion, right? And it's pure memorization, so you guys have to do that. Okay, so let's move to our next MCQ. So today we are going to try to finish these entire MCQs. So for that, you guys must be participating and you guys must be a little bit fast. Okay, so who is going to read this MCQ for us?
Try from the beginning, because we are advised that we should read only maybe from the last two sentences before going to the vitals, the major clinical presentation. So, a femoral venous access is planned for administration of IV fluid and antibiotics. The femoral artery pulsation is palpable immediately below the inguinal ligaments. Which of the following describe the optimal cannulation site of the femoral vein? Here we have an 82-year-old woman who is sent to the hospital from a nursing home after 2 days of fever, confusion, and lethargy. The patient has a history of mild dementia, hypertension, and osteoarthritis. Temperature 38 degrees Celsius. Blood pressure is 96/60, and pulse is 116 beats per minute.
Okay.
She also had mild suprapubic and right costal vertebral angle tenderness and leukocytosis. Urinalysis is also consistent with acute cystitis. So, which of the following describe the optimal cannulation site of the femoral vein?
Okay, so what's the cannulation site for femoral vein? They want you to know that. So who know the answer? What do you guys think?
Medial to the femoral artery.
Okay,
Medial to the
yeah.
femoral artery.
Okay, anterior medial to femoral artery. Okay, so do you guys have, if you guys remember, you have a mnemonic to remember it, right? Like you are going to say Lord
Vein.
Yes, the navel.
Well, okay.
Nerve, artery, vein, and then lymph nodes.
Perfect. Nerve, artery, vein, and lymph
And
nodes.
then
Right?
lymph nodes.
You guys can see, right? So let's see whether the answer is correct. Perfect. So here you guys can see, here lies your
Yeah.
after the nerve, you have your artery. After the artery, you have your vein. Gonna have like lymph node. Hello, is that clear?
Yeah. Now,
This, okay, so basically this kind of use you are going to see it in GIT, but there is some association here, right? So you must know that. Okay, NAVL. It's going to help you a lot. Okay, so let's move to our next MCQ, right? So, okay, an individual having a rheumatic heart disease, barium esophagus, demonstrate extensive compression of your mid esophagus. That bit of causes dysphagia. Yes, we did it.
Left atrium.
Yeah, left atrium.
most likely causing
Posterior aspect of your heart, right?
okay. Yeah, anatomy of the left atrium.
Left atrium basically forms the posterior, surface of your heart. Okay, which structure form the anterior surface of your heart?
Right.
Right
Right
ventricle.
ventricle is mostly at the anterior surface. Yeah.
Right ventricle, perfect, right? So here you guys can see that. Okay, we already did this MCQ, right? In our classes, I think that would be quite easy for you guys. Okay, so let's just move to our next MCQ.
Please, can
Okay,
you mute your mic if you're not talking? There is somebody called Doctor.
yeah, okay, can you guys just please fix your mic? Okay, so let's see this MCQ. A patient appeared to have severe distress. Physical examination showed deep penetrating wound in the fourth intercostal space along the left sternal border. Smaller laceration are noted across the face and forearm. Which of the structure is most likely going to injure in this patient? So who's going to read this MCQ right
Yeah.
from the beginning for us?
23-year-old woman is brought to the emergency department with a chest wound. She was in her house during a severe thunderstorm when a large tree branch fell through a window. The window was shattered and large fragments of wood and glass struck the patient. She
Okay.
did not lose consciousness, but her family found her bleeding profusely and rushed her to the hospital. Blood pressure was 80 by 50. Pulse was 130
Okay, so
beats per
she's
minute. Yeah.
right. You can see it.
Yes. Hypertensive, tachycardic. The patient appears to be in severe distress. Physical
Okay.
examination showed a deep penetrating wound to the fourth intercostal space along the left sternal border.
Okay.
Smaller laceration also noted across the face and forearms. Which of the following structures is most likely injured in the
What do you guys
patient?
Ventricle.
already
Right.
discussed? Is it left ventricle or right ventricle?
Right ventricle. Left
Right,
ventricle
right
will be
ventricle.
seated intercostal space to
Right
the
ventricle. Right. And if the same injury was directed laterally from the sternum, then it's going to be for left lung, right? Just keep this picture in your mind, okay? Hello?
Yes.
yeah.
Okay,
Yeah.
perfect. Let's move to our next MCQ. Okay. Can you just please fix your
Yes.
mic? There's some disturbance in someone's mic. Can you just fix?
A
Okay.
52-year-old man comes to the office due to chronic cough for the last 3 weeks. The patient says, I haven't been coughing up phlegm, but sometimes I notice some blood on the tissue when I cough particularly hard. He has smoked 2 packs of cigarettes daily for the past 30 years and drinks 3 to 4 cans of beer on weekend. He works as a welder on assembly line and says his
Okay.
father died of lung cancer at age 40. Physical examination showed right-sided face and arm swelling and engorgement of subcutaneous veins on the same side of the neck. Which of the following veins is most likely obstructed in this patient?
Okay, perfect. So you guys
Ear
can
and
see here, like,
cava.
it's basically coughing.
Smoke.
Please fix your
Take
mic.
your
Please, the doctor reading. When you are done, kindly switch off your mic. It interferes, please.
Please, thank you so much. Okay, so you guys can see here, this individual basically is having like like a lot of blood coming. He have like history of smoking, as well as like his father also died due to lung cancer. So all of these things are basically indicating that this individual itself is having some kind of lung cancer, right? Are you guys aware of Pancoast tumors? What are Pancoast tumors?
It's an apical lung tumor.
Perfect. So whenever we have an apical lung tumor, it can cause a lot of problem. What do you guys think? It can compress your, yes,
Brachycephaly.
recurrent
yeah,
laryngeal
it can compress. Mhm.
vein, recurrent laryngeal nerve causing hoarseness.
Perfect. It can compress your superior vena cava. It can compress your brachiocephalic vein. Okay, how to differentiate whether it's a compression of your superior vena cava or brachiocephalic vein?
Superior vena cava will be bilateral.
Perfect.
Bilateral problem will be there.
Perfect. So the idea is really clear. Like, it's just a common sense. You know that superior vena cava is basically, bringing blood from entire upper aspects of your body, right? So it's a common, like, like a common pathway for both blood coming from both right and left side. While brachiocephalic, it's going to be mostly like unilateral. Okay. So here you guys can see engorgement of. Okay, what else can Pancoast tumor cause? Okay, do you guys know Horner syndrome?
Horner syndrome.
Okay, perfect. So how do it cause Horner syndrome? What is Horner syndrome?
Compression of recurrent laryngeal nerve.
Recurrent laryngeal nerve or
Sympathetic
Sym-
nerve plexus.
Not
Perfect.
sure.
Sympathetic trunk
Okay.
clearance.
Perfect. So whenever we have like
Mm.
problems of sympathetic nervous system, like it can just like cause like most of the like third order neuron of your sympathetic basically go along with your carotids, right? So these apical lung tumors can disrupt them as well, and in that way the sympathetic supply to your face is basically compromised. So everything
It
is going
causes the ptosis
Miosis
Ptosis,
and anhydrosis.
and
myos
hydrosis. Yeah.
and hydrosis. Perfect. Keep that in mind. So what is ptosis? The eyelid is going to be it's going to be ptosis, right? Eyelid coming down.
Drooping.
Meiosis, drooping. Perfect. Okay. What's meiosis?
Capillary
Pupil
constriction.
constriction.
Pupil is constricted.
Like the idea is really clear. Whenever the sympathetic is gone, it means the parasympathetic is going to be more dominant. So what's the function of parasympathetic in case of your eye, right? So it's basically constriction, right? So the pupil is going to be constricted. And anhydrosis, right? What is anhydrosis? Half of the face won't be, sweating simply, right? So that's a problem that your Pancoast tumor can cause. Just keep that in mind. So you guys can see here is that he have right-sided face, arm, and swelling. So what do you guys think of? Whether like it can't be subclavian because the things all related to subclavian are going to more like with your hands and everything, right? So it can either be brachiocephalic or superior vena cava. So for superior vena cava, we discussed it's going to be bilateral, but since everything here is unilateral, so let's go for brachiocephalic, right? So whenever we have compression, what happens? The blood is going to stay there. It's going to lead to engorgement of your superficial vein. Shall I just move to my next MCQ?
Yes. Yes.
Okay.
Yeah.
So who is going to be reading this MCQ for us? Yes.
Shall I read them?
I'll read. This
Yeah.
patient's finding suggests compromised blood flow through which of the following coronary arteries?
Okay.
78-year-old woman hospitalized due to acute myocardial infarction. She's been
Okay.
having intermittent chest pain for 3 days, came to hospital when pain became unremitting. Has type 2 diabetes, but medical follow-up has been poor. On third day of hospitalization, patient has sudden onset shortness of breath due to pulmonary edema. Echo
Okay.
confirms severe mitral regurg. He's taken immediately for surgery, which reveals rupture of the posteromedial papillary muscle. This patient's finding typically suggests compromised blood flow through which of the following coronary arteries?
Okay, so we discussed what's the blood supply of your posterior medial papillary muscle.
Posterior
Posterior
descending.
descending.
Okay, posterior descending, right? Okay, so anyone else? Do you guys think it's posterior descending? Okay, what's the blood supply of anterior lateral papillary muscle?
Left circumflex artery.
Left circumflex and left
Yeah.
anterior descending both.
The left anterior descending is
LID.
anterolateral muscles, and for the posteromedial muscle is the PTA.
Okay, that's perfect, right? So for the posterior medial muscle, the artery. Okay, in most of individual, for example, in this kind of individual, what do you guys think the PDA is going to arise from which, right
Right.
side?
Right coronary artery.
Right dominance.
Perfect. So you
Right.
guys keep that in mind. Whenever they do not mention specifically whether an individual is right dominant or left dominant, you should assume the majority, right? That is right dominant. Okay. You should just keep that in mind. Okay. What is mitral regurgitation? You already guys discussed. What's that? Hello.
Some murmur.
Backwards flow of blood.
Okay, the backwards flow of blood, like during contraction of your ventricles, whenever your mitral valve is unable to close properly, so the blood is going to flow back, right? So let's see whether our answer is correct. That's posterior descending. So you guys can see here, right? We already discussed that you have your right coronary, your left coronary. Left coronary have LAD and your left circumflex. If an individual is left dominant, so the PDA is going to arise from his left circumflex branch of his. Okay, perfect. Okay, and the PDA itself is going to also supply the inferior portion of your heart, right? So I think that's clear. Let's move to our next MCQ. Okay, so who's going to be reading this MCQ for us? Yes, please.
Which of the following is the most likely earliest site of electric activation?
Okay,
Which
that's simple.
five-year-old
Read the other,
previously-
Okay, so what do you guys think? What's the first site of your, the dead fires?
Sinus node.
SA
This
node.
SA node.
lie. Where is SN node present?
Right
atrium near the opening of superior vena. Right atrium near the opening of the
right
superior.
atrium near the superior vena cava.
Perfect. So you guys can see it here. This is basically where your SN node is present. So you have your superior vena cava, and that is your right atrium near superior vena cava. Keep where is AV node present?
Near the
Immunotherapy,
tricuspid valve.
right ventricle near the septal cusp of
Atrium.
tricuspid.
Okay, perfect. Let's keep that in mind. Okay, you are going to have the same kind of MCQ in our. Okay, so okay, what happened? Let's see in a second. Hello, can you guys hear me?
Yes, sir.
Yes. Yes, doctor.
Who is going to be reading this MCQ for us? Yes. Hello.
The dissection flap in this patient most likely originates near the following points. Near which of the following points? A 70-year-old man comes to the ED due to severe mid-back pain that started several hours ago. He
Okay, so
described
we already know whenever we have like sharp pain radiating towards back, sharp pain radiating towards back. So whenever it's cardiovascular, just think of dissection, aortic dissection, right?
Yeah.
Okay.
Okay. He describes the pain as excruciating and wants immediate relief. The patient also has nausea, diaphoresis, and lightheadedness. He has a history of hypertension and chronic kidney disease. His medication compliance has been poor. He is an active smoker with a 40-pack year history. His blood pressure on the right arm is 220/105 millimeters of mercury. ECG shows sinus tachycardia and voltage criteria for left ventricular hypertrophy with secondary ST segment and T wave changes. After initial evaluation, a transesophageal echocardiogram shows a dissection flap in the descending aorta, but no evidence of dissection in the ascending aorta. The dissection flap in this patient most likely originates near which of the following points?
Left
Left
subclavian.
subclavian artery.
Okay, first of all, let's discuss this MCQ in a little bit detail, how you have to break down the MCQ, right? So you guys can see whenever we have severe mid-back pain that is radiating towards back, think of aortic dissection should be in your differentials, right? What else is going to narrow down this disease? The most common, risk factor for aortic dissection, what's that?
Hypertension.
Hypertension.
Perfect. So whenever we have hypertension, what happens? The intimal layer can tear. Like the intimal layer. Okay, so probably like normally your vasa vasorum are going to become more constricted. It won't be able to supply the nutrients to your intimal layer, and as a result of that, you're going to have weakening of your aorta. The intimal layer can tear, blood can enter there. You can have dissection, right? Okay, so we have two types of dissection, right? Stanford type A and type B. Can anyone just tell me what is Stanford type A? What is Stanford type B?
Type A is just a carotid arch in the ascending part, and type B will be just the descending aorta.
So my question for you guys, if we have an individual, he is having dissection flap in both ascending and descending, would it be Stanford type A or B?
Type A.
A.
Yes, it would be the type A if just
A
descending.
because A is having both
It's A.
descending and descending.
Because B only has descending.
B only descending. A having both ascending, descending.
Whenever you have ascending involved, just go for A, right? Stanford type A. So basically descending. So it means it's going to be your Stanford type B, right?
Yes.
Okay. So what do you guys think that where does descending aorta mainly starts, or what's the main point after which you can say that it's going to be your descending aorta?
Left
Left
subclavian.
subclavian artery.
To the left subclavian artery.
Left subclavian artery.
Yes.
So right, the left subclavian artery. Basically, we are going to develop this dissection flap. So here you guys can see A, and both of them are A. Like it involves only your ascending. It involves ascending plus your descending. But here you guys can see the picture, right? After your left subclavian, this is going to be your descending, right? So it always occur after your left subclavian. Keep that in mind, okay?
Doctor, what do you mean by dissection flap?
Okay, so here you guys can see that, dissection flap. So whenever the intimal layer got tears, right? So you're going to have blood here in between these two layers, right? The intima, the media here, okay? So this is basically also known as your dissection flap, right? So like, for example, let me just, okay, so you're going to be having a picture, like, for example, if this is the lumen, right? The lumen. So you're going to have formation of a false lumen here, right? Like this is going to be your true lumen. Okay, the blood normally is supposed to be here, but as it's dissecting through your intimal layer, it's entering through the false potential space, which normally do not exist in individual, right? So this tearing is also known as your dissection flap, and this lumen is also known as, like, it can also be called as a false lumen. Is it clear?
Yes, doctor.
Okay, so here you guys can see that you have type A, type B, and origination of left subclavian artery. That's important. Just keep that in mind. Okay. So yes, who is going to be reading this MCQ for us? Hello?
Yeah.
Yes, please. Go on.
Which of the following most likely explains the findings in this patient? 56-year-old man is brought to emergency department due to sudden onset severe chest pain. Blood pressure is 88, 56 and pulse is 83. On physical examination, the patient is in moderate distress. The jugular veins are distended, no murmurs or extra heart sounds are heard on cardiac auscultation. The lungs are clear to auscultation. ECG shows evidence of ST segment elevation, myocardial infarction. Besides, echo reveals contractile dysfunction of large portion of the right ventricle and normal function of the entire left ventricle consistent with the myocardial infarction involving only the right ventricle. Percutaneous coronary intervention with coronary angiography is performed and shows thrombotic occlusion affecting one of the major coronary arteries. No other significant atherosclerotic lesions are identified. Which of the following is most likely explains the findings in this patient?
Okay. Yes.
Yeah.
So here you guys can see that we have a 56-year-old. Okay, so they've already mentioned, right? So the left ventricle basically is spared. It's normal. We do not have any MI there, but we have like MI in the right ventricle, right? So what do you guys think the answer should be here?
Right coronary artery.
And left dominant.
artery.
Left dominant and
Anterior.
Okay, what do you guys think the answer should be here?
E.
E. Why do you guys think it's E? Right coronary and left dominant.
Because if the right was dominant, the left ventricle would also be involved in the inferior surface of the left ventricle.
Okay, perfect, right? So let's see whether the answer is correct. Okay. Perfect, right? So as we already discussed that your left anterior descending arises from, like we already know the blood supply, right? So we know that whenever we have an individual who is left dominant, it means that the PDA is going to be arising from the left circumflex and is going to supply the inferior portion of your heart. And inferior portion involves both your, yes,
Right and left.
right and left. But as they are saying that the left is completely spared, there isn't any problem with that, right? So it means this individual should be, like right coronary artery is basically, occluded, and he's left dominant, right? Okay, so let's move to our next MCQ. Yes, so who is going to be reading this MCQ for us? Yes.
I'll do it. Which of the following arteries was most likely obstructed during this patient's myocardial infarction? A 58-year-old man with a history of hypertension and hyperlipidemia comes to the emergency department due to substernal chest pain that began 6 hours ago and has gradually worsened. Blood pressure is 104/72 and pulse is 88. ECG shows normal sinus rhythm with ST segment depression and T wave inversion, and troponin levels are elevated. The patient is diagnosed with non-ST segment elevation myocardial infarction and admitted to the hospital for medical management, with coronary angiography scheduled the following morning. That evening, telemetry monitoring shows a new Mobitz type 1 second degree AV block.
Okay. Okay, which of the following arteries was most likely obstructing during this patient myocardial infarction? So as you remembered, we already discussed about AV nodal artery. Do you guys remember?
Yes.
Okay. So here you guys can see, okay, what do you mean by ST segment depression and ST segment elevation? We already discussed that in detail.
Yeah, ST segment depression shows ischemia and elevation shows
Which portion of
infarction.
your heart?
Yeah.
Which portion of your heart? ST depression? Hello?
Yes.
It means transmural.
Okay. ST depression is transmural or ST elevation is transmural?
Oh.
Subendocardial.
Elevation is
Yes.
Subendocardial.
Elevation is
My that
transmural.
is
Yes, elevation is transmural.
and
Perfect.
the
Whenever we have
non-ST
complete obstruction, okay, let me just ask you a question. Whenever we have complete obstruction of a coronary artery, what do you guys think? Would there be ST depression or elevation?
Elevation, then elevation.
elevation.
If we have partially occluded coronary artery, then which portion of your heart is vulnerable to ischemia?
subendocardial.
Subendocardial portion, yeah.
Perfect. So this guy developed a Morbid's type 1. What is Morbid's type 1 AV block?
It's when there's an increase in the
In that there is PR interval.
PR and it's more than 20.
Progressive lengthening of PR interval and then a sudden drop.
Okay, okay, perfect. So we have like, okay, what do you mean by Morbid's type 2? What happens in that? We do not have progressive PR interval elongation. That is direct, heart drop or like a beat drop, okay? So what do you guys think here in this case 58? They haven't mentioned whether he's right dominant or left dominant, so you should assume that he is
right.
Right.
Perfect. And as we discussed in our class, if you guys remember, AV nodal artery comes from your PD, right?
Yeah.
Yes.
It comes from PD. So what do you guys think the answer should be? Considering
Right coronary, yeah.
the answer is perfect, right? So we already discussed this MCQ in detail. So let's move to our next answer. Yes. So who is going to be reading this MCQ for us? Yes, please.
The patient's fight likely due to which of the following pathological event?
Try to read from the last 3 or 4 lines.
Okay. Yeah. Physical examination shows a grade 2 to 6 harsh murmur, best heard at the left mid to left lower sternal border. The rest of examination is unremarkable. Review of medical records shows absence of murmur at the patient find are most likely due to which of the following embryologic events?
Okay, so where do we find hollow? Okay, so based on this location,
yes,
left
ventricular
left,
septal defect.
Yes, hollow systolic murmur, left mid to lower sternal border. That's a VSG, right? So we already discussed VSG is more oftenly going to be in the membranous portion or the muscular portion.
Muscular.
Membranous. Membranous is weak portion, and that's why
yes, that's the weak one. Okay, and basically your endocardial cushions have information of this membranous portion of your interventricular septum. So what do you guys think the answer should be?
Insufficiency development of the interventricular septum D.
Okay, so let's see whether your answer is correct. Perfect. Okay, so we already know there is a hollow systolic murmur. You should know the location. Keep that in mind. Okay, where do we auscultate different murmurs, right? Where do we auscultate, like if we have any problem like stenosis or regurg of your mitral valve? What's the best place or location to auscultate those kind of murmurs?
left.
Sorry?
Apex.
Apex. And where do we find apex?
Left.
Ventricular line.
Midclavicular. Left fifth intercostal space.
Right? So let's move to our next app. Okay. So Steph Aureus, yes. Who's going to be reading this MCQ for us? Yes.
Blood cultures gross Steph Aureus, and chest X-ray shows bilateral nodular lesions with areas of cavitation. The valve most likely affected in this patient can be best evaluated by auscultation at which of the following sites? A 33-year-old. Yeah.
C.
Okay. If you guys remember, okay, we have an individual. He is like intravenous drug abuser, right? So which bug is going to cause endocarditis in those individuals?
Staph aureus.
Staph aureus and which
tricuspid. Tricuspid.
Do we auscultate problems or okay? It's going to be regurg or stenosis.
Regurgitation in the
Regurgitation of the tricuspid valves. Yeah.
Okay, so what do you guys think? Where do we auscultate this? Okay, so you guys it's one
Option 3.
C. Okay, so let's keep that in mind. Okay, which kind of murmurs do we auscultate here at B?
pulmonic.
ASDPDA.
Systolic
A
murmur
for
and AST.
Aortic.
Class, aortic stenosis.
Aortic stenosis.
All right.
Aortic stenosis.
Okay, so just remember it's pulmonic, aortic, C for your tricuspid, D for your
And mitral.
Mitral.
mitral. Okay, perfect. So what do you guys think the answer should be? It's C, right?
The answer is C.
Yes.
Perfect. So here you guys can see, okay? So tricuspid and everything. So let's move to our next MCQ. Yes, who's going to be reading this MCQ from here? Yes.
Amen.
Yes. Anyone? Yes, please.
During the procedure, a portion of his great saphenous vein is removed and grafted to one of the diseased coronary arteries to bypass its atherosclerotic narrowing.
Okay.
The vein used as a graft during this patient's procedure can be accessed at which of the following sites?
Yeah, so it's a pure anatomy, right? So, okay. So, for example, if we have multiple blockade of your, let's suppose, coronary artery, right? So, which kind of intervention are we going to, like, perform in that individual? If you have multiple blockade of your coronary artery. Okay, if we have a little bit blockade or one blockade of your, let's suppose your coronary artery,
Then we do the angioplasty, and in case of multiple blockade, we do the bypass surgery.
okay. Okay, so
internal
memory artery. Whose mic is this? Hello. Okay, perfect. So, what do you guys think? Where do our saphenous vein lie? Right? Do you guys know the anatomy? It starts from the medial malleolus, moving upward. Can you please fix your mic? Hello.
Wait.
Okay. Yes. What do you guys think is the anatomy of saphenous vein? You guys already know that.
Infralateral to pubic tubercle.
Infralateral to the pubic tubercle.
Lateral to pubic tubercle. Perfect. So you guys can see here it starts here, it would move like that. It's your pubic tubercle. It's inferior lateral to your pubic tubercle somewhere here. Okay, just keep that in mind. It's a pure anatomy memorization. Keep this picture in your mind. Okay, so let's move to our next MCQ. Yes, who's going to be reading this MCQ from here? Contrast. Enhanced CT scan. No abnormalities in your uretary kidney, but does reveal compression of left renal vein between superior mesenteric artery and aorta. Which of the following most likely to develop due to vascular? Yes. You guys know
Varicocele.
Nutcracker effect. What is nutcracker effect?
Varicocele.
Nutcracker effect. This is compression of the renal vein between aorta and the superior mesenteric.
Okay.
Yeah.
So in which so do you guys know the anatomy that basically your gonadal veins are going, okay, on the left side the gonadal veins are first of all going to drain into your left renal vein, but on the right side it directly drains into your inferior vena cava, right?
Yes.
Yes.
So whenever we have problems with left, for example, if it's nutcracker effect, one other thing, renal cell carcinoma. Do you guys know renal cell carcinoma loves to invade hematogenously, right? So whenever we have renal cell carcinoma, again, it's going to invade into your left. For example, if it's left-sided, it's going to invade into your left renal vein. And as a result of that, we know on the left side, due to anatomy, we don't know like its nature, right? So what happens that gonadal veins are going to drain into your left renal vein. So as a result of that, we are going to have varicocele. So what is varicocele? That is dilated
veins.
Form plexus within the testicles, right?
Yes.
And bag of worms, right? Bag of worms. You guys know that?
Yes, yes.
Okay,
yes.
so here you guys can see it's your nutcracker effect. Whenever we have compression of the left renal vein, as we know that the left-sided gonadal veins are going to drain into your left renal vein, while on the other hand, the right side it directly drains into your inferior vena cava, right? So whenever we have renal cell carcinoma that invades your left renal vein here, so you are having competence of this venidal vein as well, which is going to be like as in the form of dilated pampaniform venous plexus inside your testicle, right? So you guys can see it's a nutcracker effect. Okay, and yes, shall we just move to the next MCQ?
Yes, doctor.
Yes.
Okay, yes, I just remember this MCQ. I think it's okay. What is aortic stimulus? I think it's related to that. Okay, who's going to be reading this MCQ for us?
I'll read it.
Yes, please.
The pulse is no longer detectable, and the cardiac monitor demonstrates sinus tachycardia. Despite aggressive resuscitation effort, the patient dies. Autopsy examination is most likely reveal an injury involving which of the following areas of the thoracic aorta?
Okay, let's discuss this MCQ. Okay, for example, if you have a decelerating injury, so what is a decelerating injury? Do you guys know that? Hello?
I think it means that the car was decelerating when it hit the impact.
Like for example, whenever the car is like moving in a high speed and suddenly we apply some brakes, so it's going to be your decelerated injury. In decelerated injury, basically we are going to have rupture of a specific area of your aorta that's known as isthmus, right? So can you guys just tell me where is the isthmus?
C.
Okay. So my question for you guys is that why would we be having a rupture of isthmus?
Because the
narrow
proximal,
constricted segment in the aortic arch. That is part of
proximal to
aorta.
this point,
Yeah.
the aorta is fixed.
It is fixed part.
It is just distal to the origin of subclavian artery, and it is the most narrowest part, constricted segment of the aortic arch.
Fixed with PDA.
It's basically fixed part. Like you guys can see, it's tethered by these vessels. So both like the D portion and the B, they can easily move, right? But this is the fixed part. So whenever like both the P and D are moving while we have a fixed part, so all of the impact is going to be experienced here at the isthmus, right? Which can lead to, tear of the entire three, layers of your aorta, which can lead to, profuse bleeding there, lead to hypotension. So, or isthmus, just keep that in mind, okay? So what do you guys think the answer should be? It's C. Let's see whether it's correct. Perfect. So you guys can see right here, whenever a patient is having a decelerating injury, the fixed part is going to be here, while all the, like you guys can see here, right? The ligamentum arteriosum basically hold this part. So both of these places, they can just move, while the fixed, all of this impact or the force is going to be experienced specifically at the isthmus. That's why in decelerating injury, we are gonna, that's blunt, aortic injury, right? Blunt B, okay, aortic injury, BAI, okay? So you guys should know why, because the isthmus is, a static part. That's why all of the impact is going to be experienced here at the isthmus. Is that clear?
Yes.
Hello?
Yes.
Okay.
Yes, sir.
Let's move to our next MCQ. Okay, so let me just read it for you. ECG shows normal sinus rhythm. Doppler ultrasound ablation of your left vertebral artery reveals retrograde steel. Remember, it's steel. What is retrograde flow?
Subclavian steel
Backward flow.
syndrome. Subclavian
Yes,
steel syndrome.
syndrome, right? So here already they have mentioned that whenever like we have, okay, so in subclavian steel syndrome, we are going to have narrowing proximal or distal to the vertebral artery.
Proximal.
Proximal.
Proximal to the vertebral artery.
Proximal nerving, what happens, you are basically like making a gradient for the blood to flow in the backward direction. That is, blood is going to flow back from your vertebral arteries. As we know that vertebral arteries is going to perfuse most of the portion of your brain, right? Like the vertebral arteries basically, we'll be just discussing that in our neuro section in quite detail. So from the subclavian artery arises your vertebral arteries, right? Vertebral arteries are going to join at, yes, where? Ponto medullary junction. They are going to form basilar artery. Basilar artery is then going to give a lot of branches, that is spica, ica, superior cerebellar and posterior cerebral, right? If you guys remember. So it means that it's going to supply certain areas of your brain. So now whenever the blood is moving away from your brain, so what would be the symptoms? Would we be having like vertebral basilar insufficiency, dizziness?
Syncope.
Syncope dizziness.
Yeah.
The occasional dizziness, the symptoms occurs while playing table tennis. Why?
Because there is activity and blood goes toward the
Because
actual limb.
subclavian also supplies your upper extremities as well. So we are going to be having like, ischemic pain in the hand as well, because we have stenosis, we have narrowing, right? So you guys can see here, right? So history of coronary artery disease, the patient have smoked. Okay, he have a history of smoking. There might be some atherosclerotic plaque there. For the atherosclerosis, the major risk factors, you guys know, are smoking, which would just cause your endothelial damage, and history of coronary artery and stroke as well. Okay, so what do you guys think the answer should be? Which of the following artery is most likely to be occluded based on the ultrasound
Left
finding?
subclavian.
Left subclavian.
Left subclavian. That's perfect. Here you guys can see we have narrowing here. So the pressure here is like above this point is going to be low, and you do not have narrowing here. So here the pressure is going to be high. Blood always flow from high to low area, right? From higher gradient to lower gradient. So the only pathway which the blood can move is this, your vertebral artery. But as a result of that, we are going to have steel or retrograde backward flow of the blood here, right? And as it's also supplying your upper extremity, so with a lot of like for example, if an individual is playing a table like a tennis, he's using his hand, so he's also going to experience some ischemic pain in his hand as well, right? You guys can see related to arm ischemia. Okay, vertebrobasilar insufficiency, dizziness, vertigo, dropitis. Okay, shall we just move to the next MCQ?
Yes.
Yeah.
Yes.
Okay, perfect.
Yes.
So, yes, who's going to be reading this MCQ from here? The blood oxygen saturation measured from each of the samples are 71, 64, 62, 55, 42. The sample with greatest oxygen saturation most likely obtained from which of the following blood vessel? Researcher conduct a study in animal fetus, okay, fetal circulation. The fetus is delivered closely to the term and cesarean delivery prior to placental separation and initiation of pulmonary respiration. Blood samples are simultaneously collected from. Okay. Can you guys just tell me the okay? Let me just ask you some question. Okay, regarding the fetal circulation. So fetal circulation is going to be like the blood is going to be coming from umbilical vein or artery into
Vein.
the oxygenated.
Umbilical vein.
Vein.
Then it's going to move upward. It's going to be having a shunt. What's the name of that shunt?
Venosus.
Okay, so the blood is going to be entering into your inferior vena cava.
Inferior vena cava.
Inferior vena cava, perfect. And as from the inferior vena cava, it's going to move into the right atrium. From the right atrium, we have a shunt. What's the name of that shunt?
Foramen ovale.
Perfect. If some of the blood, let's suppose by any chance move to your right ventricle, then again it's going to move into pulmonary artery. Again, here we have a third shunt. PDA.
PDA.
So if all of the blood is coming, okay, let's just now discuss this MCQ. If blood is coming, it have bypassed your liver via ductus venosus, enters into inferior vena cava. So it means that the saturation is going to be like quite great, right? That is going to move into right atrium. Foramen ovale. So what do you guys think? The greatest oxygen saturation.
Inferior vena cava.
Umbilical vein.
So here you guys can see umbilical vein. It's going to bypass it, enter into your inferior vena cava, and here you guys can see. Okay. So let's move to our next answer. Yes, MJ. Who is going to be reading this MCQ for us? Yes, please.
Compression ultrasonography with Doppler reveals DVT in the right popliteal vein. A filter placement is planned to prevent embolization. A section of the patient's abdominal CT at the level of L2 is shown in the image below. The filter will most likely be placed in which of the following structures?
Okay. Yeah. So let's read this MCQ form here. Okay. Yes, you can just please start reading this MCQ from the first lines.
Okay. A 63-year-old man comes to the emergency department due to pain and swelling of the right calf. He has a history of recurrent gastrointestinal hemorrhage and was discharged from the hospital 4 days ago following a prolonged admission for diverticular bleeding requiring multiple blood transfusions. Temperature is 36.7, blood pressure is 110/60, pulse is 92, and respirations are 18.
Okay. Okay. Perfect.
I think it's B.
Okay. You guys can see here he have DVT, right? And right popliteal vein.
Yes.
Along with that, he's also having gastrointestinal hemorrhage. Okay, so what do we give for an individual if having DVT? Which drugs are we gonna give him, right?
Anticoagulants.
Anticoagulant. But if he's having gastrointestinal hemorrhage, so can we just give?
Oh, yeah.
No,
Yeah.
we cannot give.
He's already having history of like you are just making the blood more thin, and you are just causing a
Yes,
lot
more
of
bleeding.
More
Yeah.
bleeding, yeah.
What should we do?
That's why filters should be placed. Filter should be placed.
We are going to place some
Green field filter.
Where are we going? Okay, let's discuss. Normally, for example, if the DVT dislodges, it's going to move into your heart. Okay, as DVT is present in the inferior portions of your body, so all of the blood from the inferior portion of body is brought to your heart by your Perfect. So what we are going to do, we are going to adopt a smart technique. We are going to place some doors there, right, in order to prevent pulmonary embolism, right? Okay,
Yes.
if this individual was having, let's suppose, ASD, then would there be any pulmonary embolism or paradoxical embolism?
Paradoxical then.
Paradoxical.
Perfect. And this way you can just relate MCQs with one another. Okay. So what do you guys think? Okay. So whenever you are viewing like this CT scan, just think of that you are looking towards the patient from his foot side, right? From his foot side. Like imagine whenever you see certain kind of CT scan pictures, imagine that you are looking like the individual is lying on the table and you are looking from his foot side. So if we are looking from his foot side, this area. So this is going to be the right side and this is going to be the left side. Does that make sense? Just imagine. We're looking from the foot side.
Yes.
Foot side, right? So this is going to be the right side. This is going to be the left side. Right?
Yes.
We know that. We know
Yes.
that aorta is okay. This is your vertebral column, right? Aorta is present, like the abdominal aorta is present to the right side of your vertebra or to the left side.
Left.
And to the right side, what do we have?
Descending.
Inferior vena cava.
Left.
Vena cava.
Aorta is left. To the right side, we are going to have inferior vena cava. Okay. To the right or left?
To the right.
Right side.
The
Right
right.
side.
The right side, and this was the left side. So this C is going to be your
Inferior vena.
Aorta.
He is aorta.
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 right.
Abdominal aorta.
We are looking from the foot side. So this is the right side. This is the left side.
B will be the inferior.
So B is going to be your.
Inferior vena cava.
Let's see whether we are correct or not. Perfect. You guys can see here, right? It's the right side, it's the left side, and to the left side we have aorta. To the right side we are going to have inferior vena. Shall we just move to the next MCQ?
Yes.
Yes.
Perfect. Okay, so the SS site is in the right femoral vein. Okay, so an ablation catheter is advanced into the left atrium where radio frequency energy is used to eliminate the ectopic foci of abnormal electrical impulses. Do you guys remember AFib?
Yes.
During this procedure, the catheter is most likely passed through which of the following structure? Let's see this MCQ. Let's see whether yes, it is atrial fibrillation. So in the atrial fibrillation, let me just ask you some questions. We are going to have electrical foci near which structures? One of your MCQ.
Pulmonary vein. Pulmonary vein.
Pulmonary vein.
You're going to have stasis of blood there. So yeah, if we have stasis of blood, you're going to have clot formation in which structure inside your left atrium?
Left atrial appendage.
Atrial appendage.
Perfect. So if I want to, like radio ablate, what is radio ablation? Just burn those ectopic sites which are sending a lot of signals, 200, 300, and 400 impulses. So what would we do for that? We are going to burn those sites. How do we get access to your left atria? We have to cut your interatrial septum. Right? Like that makes sense. If we want to just go through the the normal pathway as the blood is flowing, we cannot move into the left atrium, because as we just move through the right ventricle, pulmonary artery, so the vasculature is going to become very thin, very narrow, so we cannot reach there. So it's easy to just move into the the right atrium, cut the interatrial septum, and just go into the left ventricle and just burn those sites. So what do you guys think the answer should?
B.
B, because it's the narrow.
B.
Go through
Okay.
the OLS.
Perfect. You guys can see it here. Inferior vena cava, right atrium, just cut it, move here, just burn those sites near the pulmonary vein, right? And AFib is going to be corrected. Shall we just move to the next MCQ?
Yes.
Yes.
Perfect. Okay, so who's going to be reading this MCQ for us?
Me. Evaluation of the left and the right coronary arteries reveals left prominent
Left.
circulation.
Hmm.
A stenotic region is identified in one of the coronary vessels just before the origin of the artery supplying the arterioventricular node. Which of the following arteries is most likely affected?
That's easy. In the left dominant individual, the PDA is going to be arising from
Left
Left
circumflex.
Left circumflex artery. Yeah.
perfect. And AV nodal itself is going to arise from the left side circulation, because we discussed AV node comes from PDA as he is left dominant individual. So the PDA is going to be where? Okay, perfect. Okay, so let's move to our next MCQ. Okay, so who is going to be reading this MCQ for us?
Which of the following is the most likely cause of the observed finding in this patient? A 37-year-old woman.
Okay, we already discussed this MCQ if you guys remember. Agitated normal saline injected in order to diagnose which condition. We discussed it.
PFO.
That is
ASD.
ASD. So what do you guys think the answer should be?
Incomplete. D.
Okay, okay. So we discussed the entire details of this pathology. Let's just move to our okay. So we are going to be discussing two more MCQs, and Dr. Moaz is here. He is going to continue with the lecture. Okay. So who is going to be reading? Okay, the initial ECG show SC segment elevation in grade 1 and AVL. Cardiac enzymes are elevated. Emergent cardiac catheterization in this patient will most likely show occlusion of which of the following arteries? Yes, you guys can see here that 51-year-old is brought to emergency department due to chest tightness that started 30 minutes prior to arrival. This chest discomfort is associated with shortness of breath, nausea. The patient was shoveling snow, his driveway where the symptoms began. Yes, what do you guys think they are just asking?
Which artery? So it will be the left circumflex.
Left side of
But this
the
lateral.
AVL.
It's lateral.
Inferior. So yes, what do you guys think the lateral borders of your heart is supplied by which artery?
B, option B.
Let's see whether the answer is correct.
left circumflex makes sense.
So this is going to be our last MCQ. Okay, what's this part?
Atrioventricular sulcus.
What's this part? Okay, so let's.
Atrioventricular
It's an
atrioventricular groove.
Yeah.
It's an AV groove, right? Your ventricles and your atria. In between that, you have AV groove.
Yeah, coronary sinus.
Okay,
groove.
perfect. Okay, so this was all about today's discussion. Hope so you guys enjoyed the session. And Dr. Moaz is here. Hello, Dr. Moaz, are you here?
Hello everyone. Yeah, I'm here, Dr. Ahmed.
Thank you so much. Okay, so let me just, just give me a second. Yes, Dr. Moaz, you can just start the lecture.
Okay. Okay, just give me a second.
Excuse me, Dr. Ahmed. Good morning. Excuse
Good
me,
morning.
Dr. Ahmed. Good morning.
Yes.
Please, on Saturday, the day before yesterday, most of us missed Dr. Moa's class, and it wasn't recorded. When we
Yes.
realized that he was calling, it wasn't recorded. What are we going to do for the Saturday
Okay.
class
So
that we
okay.
missed?
So as Dr. Moss complete the session today, in the end, I'm going to give you an overview, right? But you have to tell the topics, and I'll just give you the overview. Okay.
Okay, okay. Thank you. Thank you, Doc.
Okay, guys. So, welcome. I hope all of you are doing well. So, today we'll be starting our discussion from aortic dissection, right? So, the last time we had studied traumatic aortic rupture, and now we'll start from the next one. Okay, guys. So, so today we are starting our topic from aortic dissection, right? So, guys, what is aortic dissection, right? So, if we have to look at this picture, we can see aortic. So, I told you that aorta had three layers, right? So, this was the intima. So, this was the first layer of the aorta, and then this was the second layer. So, this was the second layer. So, we are going to focus on these two layers right now, right? So, if this was the aorta, it had two layers, right? This. So, if you see here, there are two layers of aorta. So what happens is that in the intima there's a tear of the aorta, right? So there is a tear in the intima of the aorta, and when there is a tear in the intima of the aorta, what is going to happen is that a new lumen is going to form in the intima, right? So a false lumen is going to form in the intima of the aorta, and that thing is known as the aortic dissection, right? So how could this thing come to you in your exam, right? So now remember one thing from here on, that some presenting complaints are exceedingly common in the step 1, 2, 3 exams, right? And the most common complaint that comes in the step one is the chest pain, right? So a lot of people in the step one exams are going to come to you with chest pain. So you should know the different causes of chest pain. Last time we did a cause of chest pain, that was thoracic aortic dissection, thoracic aortic aneurysm. And in thoracic aortic aneurysm, the main thing that was present was that the patient was having chest tightness as well, right? So there was chest pain and there was chest tightness as well, and that was going on for a long amount of time. And then that chest tightness was pressing on the aorta, and that was causing problem in the heart, right? So that was thoracic aortic aneurysm. In case of aortic dissection, you are going to have a person who is coming in with chest pain, and that chest pain is going to radiate to the back, right? So that is the main thing. So now there are some other conditions in which there is chest pain and that chest pain radiates to the back. What are those conditions? So there's another condition which is known as the acute
Peptic
pericardite.
acid.
So the aortic dissection. In aortic dissection, there is chest pain that is going to radiate to the back as well. So how do you differentiate between these conditions, right? So in case of aortic dissection, the main thing you're going to see is the main problem in aortic dissection comes from here, right? At this point. Normally the problem comes here at this point. So what is going to happen is that the blood supply to the left side will be normal. Sorry, the blood supply to the right side is going to be normal, and blood supply to the left side is not going to be normal, right? And when there will be a difference between the blood supply, there would be unequal blood pressure in between both arms, right? So now they are gonna give you a question that a 45-year-old male comes and that male is having hypertension, because hypertension is the biggest risk factor for a aortic dissection, or that person is having bicuspid aortic valve, or that person is having Marfan syndrome. And how does Marfan syndrome presents? Marfan syndrome presents with a patient who's having a very big height, right, or very big arms. Now, all of a sudden, this patient is having Marfan syndrome, and then you are going to see a person that he is having pain. That pain is graduated into the back, and there would be one important thing: you would see the blood pressure, and they would have given you blood pressure of two arms, and the blood pressure in the left one would be very high, and the blood pressure would be right palm below, and there would be a difference between those blood pressures. Now, they could say you that the chest X-ray shows mediastinal widening as well. This is the classic picture of aortic dissection. The next thing that you want to remember is what are the types of aortic dissection. So aortic dissection has two main types. One is the ascending aortic dissection and the other one is the descending aortic dissection. So this part is known as the ascending aorta. If if aortic dissection involves the ascending aorta, then it is known as the ascending aortic dissection, right? If an aortic dissection only involves the descending aorta, then it's known as the type B aortic dissection. Right? Why is this thing important? Because in case of ascending aortic dissection, you have to do surgery. So if a patient with ascending aortic dissection comes to you, the main treatment for this patient is going to be surgery. Again, if a person with ascending aortic dissection comes to you, you are going to do a surgery of those patients. But if a patient of descending aortic dissection comes to you, you are going to give the patients beta blockers. This is a very big difference between. And now they can ask you, why do you give the beta blockers to these patients, right? So that is the second question that they can ask you this. Why do you give beta blockers to these patients? What's the benefit of giving beta blockers to these patients? Now, if you look at beta blockers, one thing that you are going to see is that beta blockers. So now, if you look at the pathophysiology or the physiology of the pharma, beta blockers are going to act on the heart, right? And when they act on the heart, they are going to cause less activation of protein kinase. And when there is less activation of protein kinase, less calcium is going to come into the cell. And when less calcium is going to come to the cell, less amount of blood is going to be ejected from the heart. Less would be the amount of contraction. And when lesser amount of blood will come from the heart, aorta will have less stress, right? There will be less blood in the aorta and the condition is going to improve. But again, you could give beta blockers only in the descending aortic dissection, right? So you got beta blockers in the descending aortic dissection, right? So now I want to show you some pictures that these pictures are important. Show you the pictures. Now we have some CT scans of the aorta, right? And if you look at the CT scans, you can have two CT scans. As we discussed yesterday, that we are going to do CT scans of everything that comes with at that time, right? So if you look at this CT scan, the thing here is known as the ascending aorta, right? So in a CT scan, the first part, the part that is in the front will be known as the ascending aorta, whereas the part that is towards the behind or towards the vertebrae, that would be known as the descending aorta. So if you look here, there is no problem in this part. This part is completely normal, right? So again, this part is completely normal. So no problem is happening here. And the problem is here. So this is known as the crescent sign. So you are seeing a moon-like appearance here. So this is forming a moon. So this is forming a moon and this is known as the crescent sign. So whenever you see crescent sign in ascending aorta, it means it is a type A aortic dissection and the treatment for that is going to be surgery. Whereas if there is aortic dissection in the descending aorta as well, or in the descending aorta only, you give beta blockers to those patients, right? So you give beta blockers to those patients, right? So let me show you some of the picture if there's a picture of descending type B. So right, so there's no good picture of. So now again here, the picture is regarding the ascending aorta, and you can see that there is a problem in the ascending aorta, right? And there's a problem in the descending aorta as well. So it is a dual aortic dissection, and that again comes into the type A category, right? Now, okay, now so this is a picture of the myocardial mediastinum. You can see the mediastinum is so much wider than the aortic dissection, right? So Now, this is how aortic dissection is going to come, and these are the important points regarding the aortic dissection. Okay.
Doctor, I have a question. After the
Yes.
formation of a false lumen, where does the blood will go?
So almost half of the blood is going to go into the false human, and half of the blood is going to go into the body through the aorta, right? So what will happen is that, what does false human mean? False humans basically means that, for example, if you have a water bottle, right? So water bottle has an outer layer and an inner steel layer. So what if I say you that form a new layer between these two layers, right? So blood is gonna go, or the water is gonna go between those two layers, right? So this is what we mean by false human. So a lot of blood is gonna go into the false human, right? Right. Let me give you a good example of this, so you understand this, right? So, for example, just imagine that your blood vessels are like a hose. So they are just like a water hose or a water pipe, right? So normally the blood will go through the hose, and it will, that is known as the true lumen, and then it will go to the garden, and the garden is your vault, right? So now just imagine that in the hose, so in the water thing or in the pipe, now there is a break, right? So there is a break in your pipe, or there is a break in the plastic of the hose. Now between the plastic there is another passage right now. So now that path will be known as the false lumen. That is the new abnormal path, and the blood is gonna go there, right? So why is it dangerous? This is dangerous because the blood is not supposed to flow there, right? it can cause it can cause blockages, or it could even rupture the vessel, right? And when the vessel ruptures, you're gonna get a lot of serious outcomes, right? So you can get aortic regurgitation, or you can get cardiac tamponade, right? So now we would go over the details of cardiac tamponade as well in some seconds, right? So this was regarding the aortic dissection. Now, um, let me pull up something for you guys. Okay, just wait a second. So remember that now let's recap some pathophysiologies, right? So all of these things are happening in the intima. So right. So if there is intimal fat formation, so if there is intimal fatty changes, what does this condition stands for? What does this pathophysiology stands for?
Atherosclerosis.
Yes, so that would be atherosclerosis. Then if there is intimal tearing, what does this means?
Dissection.
What if there is intimal hyalinosis? What does this mean?
Arteriosclerosis.
What type of arteriosclerosis?
Monkey.
So that would be hyaline arteriosclerosis, right?
Hyaline necrosis. Okay.
Nice. If there is medial hypertrophy, right? So if I say if there is medial hypertrophy, what does this mean?
Hypoplastic.
Hypertension.
Hyperplastic.
Exactly. So that is going to be hyperplastic. So that would be hyperplastic arteriosclerosis, right? Now, if there is obliteration of the vasa vasorum, what does this thing, in which condition will this thing happen?
Syphilis.
Or syphilis.
Yes. So that would be syphilis, right? So if there is transmural inflammation of aorta, in which condition, when will this thing happen? Transmural inflammation.
Abdominal aortic dissection.
So that would be abdominal aortic aneurysm, right?
Transmural.
Right. So transmural inflammation of aorta, and that means abdominal aortic aneurysm, right? And if there is medial inflammation, right? So if there is medial inflammation only, then that means that the patient is having thoracic aortic aneurysm, right? Thoracic aortic aneurysm. So keep these pathophysiologies in your mind, right? So these pathophysiologies are important, right? Okay. Now another thing, right? Another thing is that what if I tell you that the aortic dissection is a type B aortic dissection, right? So which artery would the aortic dissection be near to? I want to know which artery is the dissection gonna be affecting.
Descending.
Right, so that would be descending aorta, but which artery, which branch of the
Left
descending aorta?
subclavian artery, maybe?
Yes, so that would be left subclavian artery, right? So in aortic dissection type B, left subclavian artery or the isthmus is affected. So the aortic isthmus is being affected in that left subclavian and as well as in the traumatic aortic rupture as well, the left subclavian artery is affected the most, right? Similarly, in type B aortic dissection, left subclavian artery is affected the most. Okay, that is one thing. Now just remember this thing in mind because this thing is important. What if I say you that a patient is having a cardiac condition near the renal arteries? What would be that condition?
Abdominal aortic.
Aneurysm.
Yes, so it would be AAA. So it would be triple A. And then I could ask you, what's the biggest risk factor for this condition?
Smoking.
Smoking.
Yes, so that would be
Smoking, yeah.
smoking, right?
Smoking.
What if I say you a cardiac condition, a cardiac inflammation or inflammation of aorta is affecting the esophagus? So right. So what would be the pathophysiology then? Right.
Dysphagia.
Mitral stenosis.
Mitral stenosis is the pathology. Mitral stenosis.
Mitral regurgitation and
So it would be
stenosis.
mitral stenosis, or again, it could be thoracic aortic aneurysm, right? So it would be thoracic aortic aneurysm.
Microstenosis. Compressing.
Now, one thing that you want to always want to remember is that whenever a patient is having aortic dissection, that patient also has aortic regurgitation as well. So aortic regurgitation is common with aortic dissection. So don't worry if they give you a question and there is a murmur as well. That murmur would be a very common thing. So there is no problem regarding this murmur, right?
Please, I want you to explain the renal. Can you please bring down what you've written up, please? The renal artery.
Okay, so I was talking about the location of different cardiac conditions, right? So if a patient is having aortic dissection, the most common place of a type B aortic dissection is near the isthmus of the aorta, just below the left subclavian artery, right? And they love to ask this question, and they ask another question, right? So they say that a patient with abdominal pain and the pain is radiating to the back, and there's a pulsatile abdominal mass as well, comes to you with a problem, right? So what do you think will be the location of this problem? Where do you think this problem will be situated, right? So this problem is situated, so that stands for the abdominal aortic aneurysm, right? And
Below the
abdominal,
renal arteries, yeah.
yes, and the abdominal aortic aneurysm is always below the renal arteries, right? So it is mostly infrarenal.
Thank
Welcome.
you.
Now we are moving towards the most big guns, right? So that would be a very, very, very important topic of today. I hope we cover it all. Right, so that is angina, right? So what is angina? Angina is very simple.
Sorry, I have a question.
Yes.
So, for abdominal aortic aneurysm, are they going to present with dysphagia and change in voice also? Or is
No.
it thoracic aortic aneurysm?
So it's
Okay.
only the thoracic because esophagus and trachea will be located there and the recurrent laryngeal nerve as well. So the thoracic aortic aneurysm is going to present with those things, right? Whereas abdominal aortic aneurysm is going to have a characteristic abdominal pain that will be radiating to the back, right? So that would be present in case of abdominal aortic aneurysm. Okay. Now let's move some other things. So now we are going to cover an important topic, which is the angina, right? So what does angina mean? So angina means that there's a pain in the heart due to ischemia of the myocardium, right? So whenever there is ischemia of the myocardium, there is going to be pain in the heart and we are going to see the pain. So that thing is known as the angina. Now, the important thing regarding angina is that there are three types of angina, right? So one angina is the stable angina, the other one is the unstable angina, and the third one is going to be with a spastic angina. So we have three types of angina. What does stable angina means? So stable angina means that we have just read about atherosclerosis. So if a patient is suffering from atherosclerosis and a vessel now is obliterated more than 70%, right? So remember this word or remember this percentage. So if a vessel is obliterated more than 70%, it means that the patient is having stable. If it means that now the blockage is so severe that it can cause ischemia and cause pain. So that thing is known as the stable angina. So the characteristic feature of stable angina is that you want to remember all of these characteristic features for the next five diseases that we're going to study, right? So I like to remember diseases and I want my students to remember the diseases with the characteristic features and then the differentiating features between them, right? So in case of stable angina, you are going to have a pain, right? And the pain is going to get worse when you start moving, right? But as soon as you start resting, the pain is going to improve, right? So a pain that occurs with exertion or with exercise and the pain improves as soon as the patient starts resting is known as the pain of a stable angina, right? Now if a patient is having a pain that is present at rest, so it occurs at rest and it occurs because the coronary artery is gone into the vasospasm, that pain is known as the vasospastic angina, the pain of the vasospastic angina. Now the important thing here is that in case of vasospastic angina, there are, first of all, there would be ECG changes. Secondly, the patient would have a risk factor as well, right? So the patient may would have smoking, the patient may would have cocaine, alcohol, amphetamines, triptans, right? So what are triptans? Triptans are important here. Triptans are drugs which are used for the treatment of migraine. So if a patient comes to you and that patient is saying that I have a problem of headaches and for that I'm using some kind of a medication, or they could just give you a question that a 45 or 43-year-old female comes to you and that patient is having chest pain that is occurring at the rest. It occurs all of a sudden and then it stops, right? And now you are going to give this patient, so now the past medical history is significant for migraines for which she uses some drugs. What do you think is the most likely problem? So the most likely problem with with this woman is gonna be vasospastic angina, which is also known as the Prinzmetal type of angina, right? And the third type is unstable angina. What does unstable angina means, right? So this is a term that you want to remember. If this is our coronary artery and this is our coronary artery, we have sometimes we have a blockage here, right? So this blockage is known as, so sometimes you have a coronary artery and there is a blockage here, and this blockage is known as a stable angina. So there is occlusion. So right, in case of stable angina, there is occlusion here, right? Now all of a sudden what happens is that sometimes this blockage gets thrombosed. So what happens is that a lot of material gets collected here and it causes almost complete obstruction of the artery, right? So this is known as the thrombosis with incomplete arterial occlusion, right? So now what will happen is that all of a sudden the patient is going to have chest pain at rest. All of a sudden the patient is going to have chest pain at the rest. And the ECG would show changes as well. But when you see the troponins of this patient, the troponins of this patient are going to be normal, right? So the troponins will be normal. This is known as the unstable angina. Why is unstable angina important? Because unstable angina can convert into myocardial infarction or at or acute coronary syndrome anytime, right? Again, unstable angina can convert into myocardial infarction or acute coronary syndrome at any time. So myocardial infarction is a very big, so this is a very big problem. Unstable angina is a big problem, right? So we want to solve this as early as possible, right? Now we are going to move to another topic, which is myocardial infarction. Now, we were studying on the unstable angina and we were saying that there is in thrombosis with incomplete occlusion. What if this plaque gets dislodged, right? So if this plaque gets dislodged and it plaques, this plaque now blocks complete artery. This would be known as the ulceration of a plaque or the thrombosis of a plaque, right? Or right, so or a rupture of a coronary atherosclerotic aortic plaque. So what will happen is that this plaque is going. So if there was a thing that these things are going to get ruptured, and this thing is now going to block whole of this thing. So the whole artery is going to get blocked. Now this patient would have ischemia of the heart that would cause myocardial infarction. So there would be death of the myocardium, there would be death of the cells of the heart. And when we are having cells, those cells won't gonna come back, right? So this is known as the myocardial infarction. In case of myocardial infarction, when you do an ECG, there could be two things. First of all, there could be ST elevations. This is known as the STEMI, right? So this is known as the STEMI, ST segment elevated myocardial infarction, or there could be no ST segment elevations, which is known as the NSTEMI, right? So it is known ST segment elevated myocardial infarction, right? So there could be ST segment elevated myocardial infarction, then there could be a non-ST segment elevated myocardial infarction as well. What is important here is that these things occur in the case of unstable angina as well. But when you do a thing which is known as the troponins here, the troponins are going to be elevated in these people. Again, the troponins are going to be elevated here, and those will confirm the diagnosis of myocardial infarction, right? So now, what if a person with chest pain comes to you, and that chest pain is gonna radiate is radiating to the and that chest pain is radiating to the jaw, and that chest pain is radiating to the left arm as well, right? And the chest pain is going to the back as well, and the patient is having perspiration as well, sweating as well, right? So that means that the patient is having myocardial infarction. Then they could ask you, what's the next best step that you are going to do in this patient? So the next best step that you are going to do in this patient is ECG, right? And the ECG is going to show ST segment elevations, right? And then you could do troponins, and the troponins would be elevated. We are going to go into the details of troponins and CKMB in a bit, but first of all, we are going to do three other things, right? So first thing is the chronic ischemia of the heart, right? So sometimes the thing that is happening is, right? So the thing is that sometimes one thing is happening is that whenever you are having, so for example, you do not have MI, but you are having 90% blockage of your vessel or 80% of the blockage of your vessel for a long period of time. So what will happen is that your heart is going to develop symptoms of heart failure. Your heart is going to develop symptoms of dyspnea, right? And why? So now there are two reasons that this thing can happen. So one thing is the myocardial hibernation. So what is myocardial hibernation? Let's go into that. So myocardial hibernation basically means that when you are having chronic ischemia, so you are chronically not getting enough oxygen, the heart thinks that it's time to sleep some of the heart cells. So some of the heart cells or some of the heart muscles are now gonna sleep. Right. Again, I'm telling you that if your heart does not get enough oxygen for a lot of amount of time, or if you're having stable angina for the last 15 to 20 years, your heart is gonna go into sleep. Those cells which are not getting the oxygen are gonna get into the sleep. Now your heart thinks that it's time to switch off. Now, if we supply enough oxygen to the heart again, if we provide reperfusion to the heart, and reperfusion is provided to two things. One is the percutaneous coronary intervention, or the other is CABG, coronary artery bypass grafting. So after this thing, the heart gets its oxygen again. The heart is going to improve, the symptoms are going to get better, and the cells won't be hibernated anymore. So it is a reversible thing. Now, another thing is the myocardial stenting. Right? So what is myocardial stenting? So myocardial stenting is very, very, very simple. What it means is that whenever you get an acute ischemia, whenever you get a heart attack, well, the thing that is going to happen is that sometimes your left ventricle is going to go into the shock. Your left ventricle is going to go into a shock, and your left ventricle won't know that what's going on, right? And as a result, your left ventricle function is going to go down. That is known as the myocardial stenting. Now, one thing regarding myocardial function is that how do we check the myocardial function? In order to check the myocardial function, we do echocardiography, right? And in echocardiography, we see a thing which is known as the ejection fraction. What is ejection fraction? Ejection fraction basically means that how much of the heart, how much blood can the heart pump out, right? So if we are having 100 ml of blood and the heart pumps out 60 ml, then it means that the ejection fraction is 60%, right? The normal ejection fraction is somewhere between 55 plus. So 55 plus is a normal ejection fraction, right? So now if the ejection fraction goes below that, then it means, so now we usually do not need 55 ml of our ejection fraction, right? We do not need that much amount of energy for our heart. So, right. So what if I say to you that the ejection fraction is going down? So the ejection fraction has gone down to for 30%, 40%. The person is still not going to have any symptoms, but the heart has a lot of reserve for our body. The heart has a lot of reserve for our body. So whenever you start exercising, the result that the heart would have had to for our body is no get there, right? So if you start exercising, you're gonna get a lot of symptoms. If you start using the stairs, you are gonna have a lot of symptoms, right? So that is the thing regarding these things. Now, if we move to the diagnosis of myocardial infarction, so let's divide it regarding timelines. So when during the first 6 hours of myocardial infarction, the thing that will be the gold standard would be the ECG. So during the first 6 hours, we are going to do an ECG, and that ECG will tell us regarding the myocardial infarction. And after 4 hours, so after 4 hours, troponins elevate. Right. So troponins elevate after 4 hours. Now, one thing regarding troponins is that troponins remain elevated till 10 days. Troponins remain elevated till 10 days, right? So what if I tell you this is a graph? So this is a graph of the amount of chemicals, and this is a graph, and here there is the troponin level, right? Right. So this is the level of troponins, and there is here there is seventh day, and here there is 10th day. So that at the 10th day, the levels are gonna get normal. Now, what if a person is having another heart attack at 4 days? How will we know that is this another heart attack or is this some other problem, right? So how will we know? So for example, people who are having one heart attack have a very much chance of getting another heart attack as well. So how are you going to know that is this person is having another heart attack or what is the problem with this person, right? So in order to know that, we have to check another enzyme which is known as the CKMB. Why C can be important, and you world and NBMEs want to know this, and I've seen a lot of questions on these and a lot of people don't know about this. It's important because CKMB becomes normal after 48 hours, right? So for example, if a person comes to you at 1 day of MI, his CKMB is 1000 and his troponin is 1000. Now at the fourth day, his CKM, his troponin will still be 1000, whereas the CKMB will be 2 or 3. Now at the fifth day, if he gets another heart attack and you check the troponins, since it was already 1000, you cannot check that if he is having any problem right now, but the CKMB would be elevated if he is having another heart attack. So this is known as the what you call as the reinfarction, and for the reinfarction, we are gonna use the CKMB levels. Now let's move to another topic. That is very good. Yeah. We know that we at in ECG there are different leads. So there is V1, V2, V3, V4, V5, V6, AVL, 23, AVF, V7 to V9. Why are these leads important? I'm going to tell you now. So if a patient is having ST segment elevations in any lead between V1 to V4, then it means that the patient is having a problem of left anterior descending artery, right? Again, if there is any ST segment elevation in V1, V2, V3, V4, then there is a problem of left anterior descending. And I want to know, ask you guys, what areas are the left anterior descending supplies? What Nafia, regarding what can you not understand?
The hibernation in the
Answer.
next part.
Hmm?
The hibernation part in the next part.
Okay, so the hibernation part is very simple, right? So the hibernation part, so let me give you an example, right? So if you go to a lot of Siberian countries or a lot of Scandinavian countries, the thing that you are gonna see is a lot of animals go into the caves whenever there is cold. So whenever there is winter, a lot of animals are gonna go into their caves. Why? Because they are not having a lot of energy in cold. So they are gonna just hibernate there. So hibernation is a concept that we got from those polar bears or the polar animals. Similarly, in case of heart, what if I say to you that the heart is deprived of enough oxygen for the past 5 years? The heart as a mechanism will do one thing. It will just switch off some of its cell. It won't work on its full capacity, right? It is not gonna work on the full capacity. It's just like a factory. So what if I say to you that a factory is having 10 cars and out of that come cars, every car works every day. But now there's a shortage of fuel or there's a shortage of gasoline. Now 5 cars aren't working anymore and only 5 cars are working. Why? Because we have hibernated that 5 cars. So that now those 5 cars cannot work anymore. This is known as the hibernation, right? So in case of myocardium, if you cannot get enough oxygen for a long amount of time, some cells are gonna switch themselves off. and you are getting a less ejection fraction. So right, so you're gonna get an ejection fraction of 40 or 30. So now you get an ejection fraction of 30 on the echocardiogram, which is not normal. And then they would give you in the question that we have do some reperfusion therapy. So we have done percutaneous coronary intervention, of we have done and surgery. And after the surgery, the ejection fraction is 60% now. Now they are going to ask you, why is this thing happening? So this thing is happening due to the myocardial hibernation. At the same time, they could give you another question. They could say that a person comes to you with pain in the jaw. That jaw pain is radiating, and the pain is present. The heart as well. It is going to the left shoulder as well, right? So what is the most? So the most likely diagnosis, and you do troponin, and the troponins are elevated. At the second day, you do an echocardiogram, and the echocardiogram shows an ejection fraction of 20%, right? And after 10 days, the ejection fraction is back to 60%. What is the reason for this thing? So the reason for this thing is myocardial stunning, right? So the reason for this thing is that there would be myocardial stunning, right? So in myocardial stunning, this thing is gonna happen. So in myocardial stunning, this thing is gonna happen. Okay. So myocardial stunning will improve on itself, whereas myocardial hibernation improves whenever we are gonna have a a reperfusion therapy or the oxygen supply gets better. Now we were on the ECG leads, right? So we are on the ECG leads. First, let me tell you one other thing. So the CKMB thing, right? So I was telling you that whenever we have a person that comes with proper heart attack, we do, or whenever a patient comes with myocardial infarction, we do a troponin level in that patient, and the troponins are gonna be raised in that person. They are gonna be in hundreds and thousands. They are gonna be in thousands. Now, what if I tell you that on the fourth day of heart attack, this patient is again having pain that is radiating to the jaw, and you want to confirm the diagnosis of a myocardial infarction again? How can you do that? Because whenever you are having a diagnosis of myocardial infarction, the next thing that you are going to do is you're going to order a percutaneous coronary intervention. But how will you confirm this patient is having a diagnosis of heart attack? Because the troponins are still in thousands. What if you order another troponins and those will still be in thousand? How will you confirm that this patient is still having a heart attack? So you rely on another enzyme, which is the CKMB. Why? Because CKMB levels rise after a heart attack, but they become normal after 48 hours, right? So these things will become normal after 48 hours. And when these becomes normal after 48 hours, if the patient is having another heart attack at the third day, fourth day, or fifth day, you just order a set of CKMB levels, and you will confirm that this patient, whether this patient is having another heart attack or not. It's as simple as that, right? So the other thing that I was going to tell you is that in case of heart attack, we do an ECG, right? So the ECG is going to show ST segment elevations or depressions in some areas, right? So if the ST segment elevations are in V1, V2, V3, or V4, then it means that it is a problem of left anterior descending artery, right? And now we know that where we want to focus our attention on in angiography or in coronary artery bypass grafting. Now I want to ask you, what areas that the left anterior descending artery supply?
The anterior
The
lateral.
anterior.
Yes. So it supplies.
Interventricular septum and anterior and the
Anterior.
lateral walls of the left ventricle
Yes.
and
So it
interior two
supplies.
thirds of interventricular
Yes. So
septum.
let's focus our attention on the interior. So it supplies the anterior part, right? So it's gonna supply the interior part, right? Now, what if I say you the problem is in V5, V6, 1, and AVL? Then the problem is going to be in LCX, right? So the LCX stands for the left circumflex artery, right? Again, the left circumflex artery, and the problem will build in the lateral walls of the heart, right? Why I'm telling you this? Because they're going to give you a lot of questions. So in the exams, whenever you're doing the exam, a lot of questions are going to come in the real exams on ECG as well, right? So there will be a lot of questions from ECG as well. So you want to check your focus on these things, right? Then if the problem is in 2, 3 AVF, then the problem is going to be in the right circumflex, right coronary artery, or the inferior part of the heart. Now this thing becomes very important. Why? This thing is important because what if you just did a question with Dr. Ahmed, and Dr. Ahmed told you that, for example, what if a patient, so where does the posterior descending artery normally arises from?
And 70 to 80% from the right coronary.
Yes. So Normally, in 80% of the patients, if they have a 2-3 AVF infarction, there. So where will be the, so what will be the problem here?
Right coronary artery, because 80% in the cases it
Yes.
will be the in the
Okay.
right.
And what are the structures that the right coronary artery supplies? What is the main structure that the PDA supplies?
AV node and SA node.
Inferior.
Yes, so it is going to supply the AV
The
node and the SN.
ventricles, posterior
Right?
ventricles.
So now, since it's gonna supply the AV node and the SA node, and the AV node and SA node are affected, these people are gonna have a bradycardia, or these patients are gonna have a heart block. The next lecture on tomorrow will be on arrhythmias, and then we'll go into detail about them. But if you suspect a patient, or if they say that a patient is having a problem in 2-3 AVF, and then they ask you what is the most likely effect of this blocking in the heart, so the most likely effect is going to be bradycardia, right? So patients with 2-3 AVF infarctions normally come with bradycardia. They have a very low heart rate. Okay, so this is clear till now. Now, one other thing is that in case of right coronary artery, so now one other thing. Whenever the left side of the heart is affected, a lot of blood is gonna get accumulated in the left side of the heart, and that blood is going to go back to the left atrium and to the lungs. Right, so you are gonna have pulmonary edema in the case of left-sided heart failure. Whereas in the case, so now how do we prevent the pulmonary edema? We give those patients nitroglycerin. Why? Because you guys know, so since a lot of blood is going to accumulate in the heart, and we know that how can we prevent the blood from accumulating in the heart? We can give the patients a drug which is known as nitroglycerin. Nitroglycerin is going to relax the venous tone, and when the venous tone is relaxed, now uh, less blood is going to come to the heart, and by the mechanism of
Preload is decreased.
so the preload is decreased, and now less blood is coming, so the problem is solved. But in the case of right-sided coronary infection, right-sided coronary infarction, or right-sided MI, the right side of the heart is not pumping enough blood. So now what will happen is that no amount of blood is going to go to the lungs. And since no amount of blood is going to the lungs, no amount of blood is going to come to the left atrium. So the preload is very low in case of right-sided heart failure, right? And what if I say you that we give nitroglycerin to this patient? What will happen to this patient now?
Worsen the condition.
Worsen.
Yeah, it
It
will
will worsen
further
the condition.
the decrease in the
So now this is the question. So this is the crazy question that the USMLEs and NDMs give, and a lot of people just like blindly give nitroglycerin to the patient. So if a patient comes to you with pain and you are giving the patient nitroglycerin, and you're not looking at the ECG, and the ECG shows 2-3 AVF elevation, then you are killing the patient. You are simply killing the patient. So now in case of 2-3 AVF elevation or the right side NMI, you should give the patients fluids. So when you give the patients fluids, the patient is going to improve, right? The patient is going to improve whenever, as soon as you start giving fluids to the patient. Now we are going to look at the timeline of myocardial infarction. So what problems are going to happen at what time? So during the first 24 hours. So if you will give your question and this says, or then we must give your
Sorry,
question and then yes.
sorry, please. I want you to explain how fluid is going to improve myocardial infarction affecting lead 2, 3, and AVF.
Yes, I did not get your question. Can you repeat it, please?
IV fluid is going to improve myocardial infarction affecting the right side of the heart, affecting lead 2, 3, and AVF.
Yes. So
Could you please explain?
okay. The 2-3 AVF leads are more towards the right side of the heart, right? So we have different
Yes.
leads, and those leads are present in different parts of the heart when you place the leads, right? So when we place the leads, will detect signal from different parts. So the 2-3 AVF leads are placed more towards the right side of the heart. So that is why when those leads are elevated and when those leads are there, so we are going to have a problem of right side of the heart. And when right side of the heart cannot contract, the blood cannot go to the left side because the blood goes from the right side of the heart to the left side. Now, no blood can go to the left side of the heart. And as the result, the left side of the heart is gonna get very little blood. The preload of the left side is gonna decrease, and that will cause the problems. So that is why we give more fluid, so more amount of blood can go to the left side of the heart. Right? So now, what ST depression? So ST depression is very simple. ST depressions means that the patient is having NSTEMI, right? NSTEMI means non-ST segment elevated myocardial infarction, right? So NSTEMI means that the patient is having a myocardial infarction in which the end stem in which the leads on the are not elevated but they are depressed. Why is this important? This is important because STEMI is a transmural infarction. It involves all three layers of the heart. So the heart has three layers: endocardium, myocardium, and endocardium, myocardium, and epicardium, right? And then pericardium. If all of these layers are affected, then you are going to have an ST segment elevated infarction. And this is very, very worse than an infarction which only involves the end stem. And in end STEMI, only the endocardium, subendocardial area is affected. So this is mild as compared to a complete stem, right? So end STEMI is very mild as compared to a complete stem, right? So now let's do this from here, right? So if you go to the evaluation of myocardial infarction, the most commonly occluded arteries are the LAD. So the most commonly you are going to see a V1, V2, V3, V4 infarction elevation, and then there is RCA. In case of RCA, you are going to see 2, 3, and AVF elevation. Whereas in case of a circumflex, you are going to see 1 AVL and V5 and V6 elevation, right? Now, what are the signs and symptoms? I already told you there would be diaphoresis, so there would be sweating, there will be nausea, vomiting, severe retrosternal pain, pain in the left arm or joint, shortness of breath, and fatigue. Now, the first thing that they ask here is that if a person comes to you and that person is having myocardial infarction and the troponins are elevated, what is the most likely chance of this person to die from during the first 24 hours? Right. So during the first 24 hours, the patient is most likely going to die from arrhythmia, which is ventricular fibrillation, right? So during the first 24 hours, the most likely chance of this patient to die from is ventricular fibrillation. So the patient dies from ventricular arrhythmia, especially ventricular fibrillation. Right? You can just keep this and cut this, right? So the most important is ventricular arrhythmia, right? Now another thing that they're gonna ask you is that a person comes to you during the first 4 hours, right? And so they can give you a question that a person comes to you and that person had a myocardial infarction and the troponins were elevated. The ECG showed us segment elevation as well. And now the person is dead within 2 hours. And now you see autopsy of the person and that what kind of findings would you see in this patient's light microscope? So normally during the first 4 hours, no changes are present or just wavy fibers are present, which is a very normal thing. So during first 4 hours of myocardial infarction, you are not going to see any autopsy changes, right? Even during the first 24 hours, you can just see early coagulative necrosis, and that is even very hard to see, right? Then another thing is here is reperfusion injury. What is reperfusion injury? Now they could give you another question, and they could say that a person of a heart attack comes to you, and when that person comes, you do an echo during the first hour, and that person ejection fraction is 50%, right? Now, after that, you do a percutaneous coronary intervention. You reperfuse the person's myocardium. And after reperfusing the person's myocardium, now this patient's myocardium ejection fraction is 30%. What is the reason for this? So the reason for this is very simple. Whenever an area had a lot of blood blockage, that area is gonna have a lot of free radicals, right? Now, when all of a sudden you supply blood again to this area, those free radicals are going to be released into the heart, and there is going to be a lot of calcium influx, and that is going to cause a condition which is going to be reperfusion injury. So now they're going to ask, what is the pathophysiology of this condition? So the pathophysiology of this condition is going to be calcium influx and the formation of free radicals, right? So that is the things that occur in the first 24 hours. Now, during the first 3 days, there would be coagulative necrosis, as well as the tissue would show acute inflammation in neutrophil. So now how would they confuse you with this question? They would say, and the complication that occurs during the first 3 days is the post-infarction fibrinous pericarditis. What is this thing? Right? Let's go over post-infarction fibrinous pericarditis. So basically, what is pericarditis? So pericarditis is an inflammation of the pericardium. right? And whenever you are having a heart attack, there is a very chances that there would be a lot of macrophages there, there would be a lot of neutrophils there that could attack the myocardium as well, right? In order to improve the pericardium, it is going to attack the pericardium, right? So pericarditis is an inflammation of the pericardium. Normally, it occurs due to viral infections, but in this case, it is occurring due to the neutrophils that are present there. Now, what will happen is that the patient is going to have a chest pain on the first to third day. So they are going to give you a question that 30 to 35-year-old male or female or 50-year-old male comes to you, and that patient is having myocardial infarction. And on the second day, he's having chest pain that is worse when the patient lies down, and the patient pains improve whenever the patient leans forward, right? So the pain worsens when the patients lie down, and the pain improves whenever the patient leans forward, right? So what is this diagnosis? So the diagnosis would be post-infarction fibrillous pericarditis. And again, what normally the treatment for post-infarction fibrillous pericarditis is, so any pericarditis is NSAIDs plus clozapine. But in case of post-infarction fibrillous pericarditis, we do not give the patients NSAIDs. What do we give the patients? So we give the patients aspirin, high dose aspirin. Remember, in case of post-infarction or venous pericarditis, we can only give the patients aspirin. This is very heavy. Right now, after 3 to 14 days, there are going to be a lot of problems. The patient could have mitral regurgitation. The patients could have ventricular septal defect. The patient could have left ventricle sugar aneurysm. There is a whole like the lecture that we're going to have on this thing, and then there would be macrophages during the 13 to 14 days, right? And then there will be granulation tissue. And after 2 weeks to several months, there going to be a scar tissue that would be present there. Now there could be post-cardiac injury syndrome as well. We'll study that, and there could be ventricular aneurysm as well. Okay. So, so these are the myocardial infarction infections, complications. We'll go over them, each of them in detail. Right. So now we are done with the pericarditis as well, and we are done with this topic as well. Okay. So let me look at some things. So I could share some more stuff with you. Just give me a second. Okay. Now let's do the histology. Okay, guys. So if you look at this histology, this is a very completely normal histology. No problem is present here. There are wavy fibers. If you see here, there are wavy fibers, and these are completely normal. These are completely normal in a cardiac muscle because cardiac muscles have sarcomeres, and these are normal. Okay. Whereas in the case of okay, so now someone asked me last time. I think it was Abdur, and I don't think it's Abdur. Is Abdur here today? I don't think he's here today. Oh, he's here. Okay.
Yes, sir.
Okay, so you asked me what structures are basophilic and what structures are eosinophilic, right? Okay, so remember, the neutrophils are basophilic. The neutrophils are very much basophilic, right? So whenever you see a lot of basophilic structures in a place, you can think that there are neutrophils here, and that is due to inflammation, right? So now they could give you this picture, and here there would be a lot of neutrophils that would be present, and they would be basophilic. Now I have a better picture here, and let me show you those pictures. Right? Right. So this picture, you can see that there are a lot of basophilic structures. There are a lot of purple things that are here. So now, for example, they give you a question and they say that a person comes to you during the patient has a myocardial infarction and the patient died, and we are having this image. And so, what is the day that the person died from? What is the day where this picture was taken? So this picture was taken from 1 to 3 days. Right. So this picture was taken from 1 to 3 days. Right. So this is the one that is important here, and you should remember. So, right. And another thing, again, I'm telling you that during the first 4 hours, there are no visible changes in the histology. Then after 4 hours, there will be wavy changes. and in 24 hours there would be hyper, so there would be shrunken nuclear, right? So there would be shrunken nuclear, there would be hypercontraction of myofibrillation. In the first 3 days, there would be neutrophils. After first 3 days, there are going to be necrophages, and after that, there would be scar tissue, right? Okay. Now again, if we give you a question that a 57-year-old man comes to you and that patient has chest pain and proper needs are elevated and that patient died, and what do you think the patient most likely died from, right? So the patient most likely would have died from a ventricular fibrillation because if a patient of MI comes to you, that patient is most likely gonna die from ventricular fibrillation from the first during the first time sometimes, right? Again, if they give you a question that a 45-year-old male comes to the patient is having severe chest pain and diaphoresis palpitations, the patient dies 2 hours after the onset of symptoms. What light microscopic changes you're gonna see in these patients? So there will be no light microscope changes that could be present. The light microscope changes are gonna be known, right? Okay, so okay, guys. So let's speak discussion till here today. And if anyone has any questions, they can ask me any questions.
Yes.
Yep.
Sir, can you just explain the subclavian steal syndrome?
Okay. Okay. Any other question?
Yeah, can you differentiate the myocardial stunning from hibernation again, please?
Okay. 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 And Dr. Aksa?
Um, can you please show the pathologic Q waves on an ECG compared to the normal one?
Okay. 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 So now, first of all, let's go over the myocardial hibernation versus the myocardial stunning. So myocardial hibernation is simply the fact that your heart is not getting enough oxygen, right? So if your heart is not getting enough oxygen for the past 2 to 3 years, then the heart is gonna go into a state where it won't contract properly. But as soon as you give the patient enough oxygen, then the patient is gonna improve, right? So it is known as the transient reduction in the function of heart, right? Now, so this is known as the myocardial hibernation, right? So this is known as the myocardial hibernation. So what if I compared it to a human? So just imagine a human who hasn't eaten any food. So for example, that there is a patient who hasn't, or there is a person who hasn't eaten any food for the past 10 days, and that patient comes to you, right? Or that person says that I cannot work anymore. I'm too lazy. I don't have any energy. Then the most likely problem is that this patient has not have any food, so that patient fuel is low. The patient cannot function properly. This thing is known as the hibernation. So this would be very similar to myocardial hibernation. What is myocardial stunning? So what if the same person comes to you and that person said, I just had a death of my of very close family member, right? So the patient says that my father died or my mother died or my brother died and he's very sad, right? Due to that, right? And that person says, I cannot work anymore. Now the problem is not due to the lack of energy or due to the lack of oxygen. Now the problem is that the patient is in a shock, right? So whenever the heart has any shock. So, for example, you get a trauma and that shocks your heart, or you get a myocardial infarction and that shocks your heart, or you get an atrial fibrillation that shocks your heart. So, temporarily, your heart stops working properly. Temporarily, your heart does not function properly. So, this thing is known as the myocardial stunning. And after some days or after some weeks, the heart is going to improve on its own. The heart is going to recover just like a normal person recovers, right? Whereas in the case of myocardial hibernation, the main problem is that the patient is not getting enough oxygen. Now, when the patient is not getting or the heart is not getting enough oxygen, the heart will stop working properly. The heart is going to say, I'm on a strike, right? I'm on a protest. I'm not working anymore. So if you give me enough oxygen, I'm only going to work in that condition. So this is the difference between myocardial infarction and myocardial stunning, right? The myocardial stunning and the myocardial hibernation. Now, Karan, so now subclavian steal syndrome, right, Dr. Abdul?
Yes, sir.
Okay, so what is subclavian steal syndrome, right? So now, whenever, so we have a thing which is known as the subclavian artery, right? So if you see here, The third artery that comes from the heart here is the subclavian artery. So this one was the subclavian artery. Now this one was the subclavian artery. And if we trace the subclavian artery upwards, this artery is gonna give branch to the vertebral artery, right? So here there will be the formation of vertebral artery here. And vertebral artery comes from the subclavian artery, right? And this vertebral artery supplies the brain. So it supplies the posterior part of the brain, right? So now it normally supplies the hindbrain. So what if I say to you this artery is stenosed here? So this artery is stenosed here. This artery cannot supply blood to the so this artery cannot supply the blood to the vertebral artery anymore, since it is stenosed. So this vertebral artery is not gonna get enough blood, right? Okay. Now this vertebral artery will not get enough blood. Now one more thing is important here is that if so this is the left subclavian, right? Let me show you a detailed quick image. Okay, guys. So if we look at this sub artery here, and if you see the right part, so there is the right subclavian artery, there is the left subclavian artery, right? And the right subclavian artery is gonna give the vertebral artery here, and the left subclavian artery is gonna give the vertebral artery as well. And then the left subclavian artery is going into the arms, and the right subclavian artery is going into the arms as well. What if I say to you that this artery is blocked here? Specifically, is the arm gonna get enough blood supply on the left side or not?
No.
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 So the arm is gonna not gonna get enough blood supply, right? So the thing that is gonna happen is that since since the left subclavian, so let me make this picture again. Let me change it. Right. So the left subclavian was blocked here, and here it was giving the left vertebral, and here was the artery that went to the arm, right? So both of this is not gonna get this. Both of these are gonna get reduced blood supply. Now, now both of them are gonna fight for the blood supply, right? And now, what if all of a sudden I have to work with my hands? So what if I have to play table tennis, or I have to play basketball, or I have to paint something, right? At that time, the left arm is gonna need, or the arm is gonna need more some blood supply. So what will it do is that it's gonna get the blood supply from the vertebral artery. It's gonna take more blood from the vertebral artery, right? So whenever you are using your arms, you're gonna have reduced cerebral perfusion, and that would gonna cause arm ischemia as well as pain in the arm, because two things are computing, and you are gonna have dizziness, you are gonna have vertigo, right? Second thing is that since the left arm is not getting enough blood, the blood pressure on the left side is gonna be reduced as well, right? Again, the blood pressure on the left side is gonna be reduced as well, right? And both of these vertebral arteries are interconnected. So the right-sided vertebral artery is going to supply some blood from the left side. Most commonly, this thing happens with atherosclerosis, right? The most common cause is atherosclerosis. It also happens with Takayusu's arthritis. When we do rheumatology, we are going to go into the detail about Takayusu's arthritis, and we'll study it there. But simply, they would give you a question that a patient comes to you, and that patient is having arm pain whenever the patient works hard, and the patient has dizziness whenever the patient uses his arms a lot. And this patient would have atherosclerotic risk factors as well. So that would mean that the patient is having what do you know as the subclavian USMLE. Okay, Dr. Aksa, what was your question? I forgot it.
Can you please explain the pathologic Q waves on an ECG and compare it to the normal one?
Okay. Okay, so first of all, pathologic Q waves occur whenever the patient is having um, okay. So look here. So the first thing that is present here in any ECG is the Q wave. So if we look at the upper picture, the Q wave is usually one box, right? So the Q wave is usually one box. Let me mark it for you as well. So the Q wave usually in any ECG is gonna be one box in length, right? So if you see here, the Q wave gonna is negative, it goes down and it goes down almost 1 to 1.5 boxes. It won't ever close 2 boxes. Now, whenever a patient is having Q waves, right, and a pathological Q waves, you will see that this pathological Q wave is gonna go very deep. Right? So if you see here, now let's count the boxes. Right? So the boxes say that it is 1, 2, 3, and 4 waves. Right? So normally the Q wave is not very deep. It is less than 40 milliseconds, right? And 40 milliseconds usually stands for one box, right? So what if the Q wave is more than one or 1.5 box thick? Then it means that the patient is having pathological Q waves, right? And that pathological Q waves will normally occur in case of a myocardial infarction or a poor myocardial or past myocardial infarction is let. Now let's look at some other examples of these Q waves, pathological Q waves. Again, if you see this picture here, now let's count the Q waves, right? So if you see the Q wave, it is 1, 2, 3, and 4 boxes tall. So if the Q wave is that much tall, then it means that the patient is having a pathological Q wave. Now let's compare and contrast with it with a normal ECG, right? Normal pictures. Normal. Okay, yes, this one is a good one. Again, so if you see here, the Q wave is very thin, right? So it is only one box thick. But whenever it becomes very much more big, here you cannot see clearly. The ECGs that you get in your exams will be very much clear, right? So they won't have this much bad picture, but it is one block, one block long. So if it's more than one block long and it is 3 4 blocks long, then the patient is having pathological failures. Okay. Dr. Napia, what are you finding difficult in this? You can tell me and I could explain that to you.
So the pericarditis part, the complications, I don't understand. Like, you just explain all the complications, or we will do it tomorrow because the brain is so.
Okay, so basically, I listed all of those complications. Yeah. And so I just told you about the timeline, right? But we are going to go into the detailed explanation of each of these complications in detail tomorrow, right? So what does post-infarction fibrinous pericarditis mean? What does ventricular septal rupture means? What does post-infarction cardiac tamponade means? But right now, you should only remember the timelines, right? So the timelines you want to remember,
Okay,
that
thank you.
so during the first 24 hours, ventricular fibrillations happen. During the first 3 days, post-infarction fibrinous pericarditis happens. After that, during the first 14 days after that, you're going to have three things: ventricular septal rupture, mitral regurgitation, and post-cardiac injury syndrome. And after that, you are going to have chances of ventricular aneurysm. So right now, you should just remember these things. And after that, there is a whole other page regarding these things, right? So this one.
So we are gonna go into the detail about this one in the next lecture, most likely.
I thought we're done.
No, we are not done yet. We are gonna do all of these things in detail.
Okay. Thank you.
Okay. Well, you're welcome. Right. So guys, we'll limit our discussions till here today, and we're gonna start tomorrow. So all of you take care and have a very good day. So bye bye.
Thank you.
You're welcome.
Thank you so much, Dr. Moaz, for having such an amazing session. And yes, so are you guys enjoying the lectures? Hello?
Yes.
Yes,
Oh,
definitely.
that's perfect. That's perfect. Okay. So you guys should be consistent with your task. As you know, everything is just going according to the plan. So just stick to the task and, do not miss your daily task and whatever problem you have. So we are going to cover that. Okay. So there was a lecture missing. So now let's have discussion over those topics. So can you guys just tell me that what were the topics which Dr. Moaz just taught you so that I can have a
Hypertension.
hypertension, right? What else?
Atherosclerosis,
Okay, atherosclerosis. What else?
arteriosclerosis,
Artery.
Hyperlipidemia,
aneurysm.
aortic aneurysm, and traumatic aortic rupture.
Okay, so we'll be starting from aortic aneurysm, right? And then we'll be more like discussing the other one. Like that are quite simple topics. So the aortic aneurysm like need a little bit concept you must have. Okay, so we'll be starting from aortic aneurysm, right? Okay, so can you guys just see my screen?
Yes.
Okay, perfect. Can anyone just tell me what is aneurysm?
Dilation.
Dilation of the blood vessel.
Okay, perfect. So can I say that it's basically a pathological dilation of your right? Aneurysm not only is going to be present within your aorta, but aneurysm can occur in your brain as well, the perianeurysm, right? Which we'll be discussing in our neurology section, right? So aneurysm itself is basically an pathological dilatation. Pathological dilatation, right? Of your aorta in this case. Okay, you should just keep that in mind. So now you should think that what leads to dilatation of aorta, right? So for that you should be having the concept like, for example, if this is your aorta, right? So aorta normally have three layers, as Dr. Moaz just told us: your intima, your media, and adventitia, right? Okay. Another thing you should just keep in mind that your aorta is a big artery, right? A big vessel. So this vessel itself needs some nutrients, right? So the nutrients like which your intima is going to need is directly going to be, here the blood is going to be running. So from this blood, the intima can get perfused, it can get its nutrients. But we have small arteries as well, right? Which are basically going to perfuse your big vessel. And those are known as, yes, what's the name of the vasa? Vasorum. Perfect. So, okay. So now you should just think, whenever we have hypertension, what happens in hypertension? What adaptatory mechanism occurs in case of hypertension? Yes, what do you guys think?
The wall will be compressed.
Okay. Like, for example, if you have a blood vessel and we are having hypertension, so in order to withstand this increased pressure, basically your blood vessel become thickened, right? It become more elastic, right? Hello?
Yes.
Okay, it become more elastic. Okay, all of your blood vessels have this adaptatory mechanism. So for example, if we have an individual, he's having hypertension in this case. So won't you think that the vasa vasorum is going to become more thickened in case of hypertension?
Yes.
Okay, if the vasa vasorum get thickens, won't you think that the lumen size is going to be decreased? Hello?
Yes.
Okay, if the lumen size is decreased, won't you think that there would be problem perfusing your aorta?
Yes.
Okay, won't you think if there are problem perfusing aorta or aorta isn't getting a good nutrients, so your aorta is going to become, weakened, right?
Yes.
Okay, and once your aorta become weakened, so now what would happen? There would be increased chances of weakening, and as the aorta become weakened, it would lead to dilatation of that weakened part of your aorta, which is going to lead to aneurysm formation. Does that make sense?
It does.
Okay, so how do hypertension lead to aneurysm? Basically, you can just simply imagine that it would lead to thickening of your vasa vasorum, as the which is a normal adaptive mechanism. As the vasa vasorum become thickened, it's difficult for your big vessel aorta to get perfused. As a result of that, your aorta is going to become weakened. And as the aorta become weakened due to hypertension, what happens? There is going to be a focal dilatation of that weakened area, which is basically known as aneurysm, right? So we have two variants of aneurysm: thoracic aortic aneurysm and abdominal aortic aneurysm. So as the name indicates, thoracic abdominal aneurysm is going to be occurring in the thoracic region of your aorta, right?
Yes.
So how would it present? Remember, whenever we have this kind of dilatation, it's also going to cause some compressive symptoms, right? Compression, right? For example, it can lead to dysphagia. So whenever you have dysphagia in the question stem, do not always think that there is a mitral stenosis and it's compressing. Thoracic abdominal aneurysm can also lead to compression of your esophagus, giving you dysphagia. Keep that in mind. Keep both of these differentials in mind, okay? Okay. What are the risk factors as we discussed? Hypertension, bicuspid aortic valve, and connective tissue diseases, like, for example, Marfan syndrome, right? So one of the risk factor was hypertension. We discussed that how hypertension can lead to your thoracic abdominal aneurysm. So what is Marfan syndrome? Can you guys just tell me? Which gene mutation? Fibrillin?
Fibrillin 1.
Fibrillin 1. And simply you can imagine, for example, if you have a lot of collagen, fibers. So what's the function of fibrillin? Fibrillin act as a cementing particles or molecules, adhesive or cementing molecules between these collagen fibers, right? So can I say that fibrillin 1 basically strengthen your vessels, because in the vessels we also have a lot of collagen. We need these cementing molecules, right? Hello?
Yes, yes.
So for example, if we do not have these cementing molecules, fibrillin 1 gene, which lead to formation of the cementing molecules, won't you think if we do not have enough adhesive molecules, cementing molecules, there would be weakening of aorta?
Yes, doctor.
And if we
Yes.
have weakening of aorta, again, it's going to lead to aneurysm, abnormal dilatation. Okay? Hello? And what else can directly cause inflammation of your vasa vasorum? That is your tertiary syphilis, right? Obliterative. Okay? Okay. Perfect. So you should just keep these things in mind. So aortic root dilatation may lead to aortic valve regurgitation. So what do we mean by that? For example, if this is your heart, this is your aorta, and here you have your aortic valve. For example, if the aneurysm occurs here, right? So what happens? Both of these valves are going to move, like far from one another. So now we cannot close the valve. If we cannot close the valve, it's going to lead to aortic regurgitation whenever the aneurysm is in the root of aorta, right? Is that clear?
Yes.
So this was all about your thoracic abdominal aneurysm. Similarly, cystic medial degeneration can also lead to thoracic. Okay, what is cystic medial degeneration? The idea is really simple. Like, for example, we have like intima, media, and adventitia. Sometimes what happens, there can be formation of some cyst and they become degenerated, right? The medial layer. So if the medial layer become degenerated, won't it again become weakened? And if it becomes weakened, again, we are going to have aneurysm, right? Is that clear?
Yes.
Yes.
Okay, so it was all about thoracic aortic aneurysm. So what would be the presenting feature? There will be some compressive signs, dysphagia. There can be okay, and this aneurysm is weak, so it can rupture. So for example, if it get ruptured, we will be having hypotension, hypovolemic shock. So you should keep all of these things in mind. Patient having history of hypertension, bicuspid aortic valve. If you are having bicuspid aortic valve, again the pressure there is very high, right? Normally we have three cusps of your aortic valve. If you have bi, so what happens? There is going to be like increased shear forces by the high pressure within the aorta, which is again going to weaken your wall, right? So this was all about thoracic aortic aneurysm. Is there any questions? Is there any question?
No, doctor.
Okay, perfect. So let's discuss our next topic, that is AAA, right? So basically abdominal aortic aneurysm. You should just keep one thing in mind, that what is going to be the presenting feature. Presenting feature is really important in order to diagnose such kind of diseases, right? So who is going to be telling me there is a characteristic presenting feature?
Palpable pulsatile abdominal mass.
Perfect. Palpable pulsatile abdominal mass, right? Okay, like as we are having the idea is really clear, as in the abdominal aorta we are having an aneurysm, and whenever the blood changes, it's going to lead to pulsation, right? So whenever in the examination they're telling you that we have palpable pulsatile abdominal mass, think of abdominal aortic aneurysm on your differential as well, right? But as we discussed, that thoracic abdominal aneurysm was due to hypertension, due to weakening of that valve, due to the vasa vasorum become more thickened. But in case of abdominal aortic aneurysm, it's basically inflammation of your transmural inflammation of your valve. That is, the entire three layers become inflamed, right? Okay, and what lead to this inflammation? Yes,
Tobacco, smoking.
smoking. Perfect, right? As we know that smoking contain a lot of like certain amount of things which are like very toxic to your endothelial cell, that can directly cause damage. And whenever we have damage to the endothelium or any other layer, it's going to be followed by inflammation, right? Inflammatory cells are going to come there, and they're going to mainly like resolve these problems by attracting a lot of your inflammatory cells. So transmural inflammation, and whenever we have inflammation, again the wall become weakened, right? Like there the inflammatory cells can eat away a lot of things. For example, it can like eat away collagen. Okay, so there is an enzyme, right? And whenever that enzyme is activated, it's going to lead to degradation of your collagen. What's the name of that enzyme? Yes, let me just give you a clue. Matrix
proteinase.
Perfect. Matrix. Yes, what metallo
Proteinase.
protease. Okay, so it's basically okay. Which cells release these matrix metalloprotease?
Macrophages.
Your inflammatory cells, that is macrophages. So for example, due to smoking, if we have some kind of inflammation, all of the inflammatory cells are going to come there along with macrophages. Macrophages are going to release this enzyme, and what this enzyme is going to, it's going to degrade your collagen. So if the collagen is degraded, won't you think that again this part of your abdominal aorta is going to become weakened?
Yes.
If it become weakened, won't you think it would lead to aneurysm formation? Hello?
Yes, doctor.
Okay, perfect. So, and smoking is basically like most common, more common in male, right? So whenever in the clinical history you have a male a smoker, unpalpable, pulsatile abdominal mass, you should just think of abdominal aortic aneurysm, right? And again, it's a weak dilatation. It can become rupture, and once it rupture, it can lead to hypotension, right? Okay, most often infrarenal distribution of vasorum is reduced, right? So infrarenal, it can just occur mostly. Okay, so this was all about aortic aneurysm. Is that clear? Do you guys have any questions? I think like things are going to make a lot of sense for you guys. So this is also going to be one of your MCQ, which your NBM you would love to test. The one I just told you, matrix metalloprotease comes from which cells? Macrophages. Keep that in mind. Okay. Hello.
Yes, thank you.
Yes, and they're going to be asking you in abdominal aortic aneurysm, what is the risk factor? That smoking, male. Just keep those things in mind, right? And like in thoracic abdominal aneurysm, they'll be asking you, have an individual, he has some compressive symptoms. Right after that, he develop a profuse hypotension. So what do you guys think? What could be the cause of that? And he can just give you, he have some connective tissue disorder, right? That is Marfan syndrome. They'll be just pointing towards that. So you should be like quite wise to get this MCQ. Is that clear? Hello?
Yes.
So let's discuss our next topic, that is going to be hypertension. So I think hypertension is a really easy one, right? So I'll be asking you guys some questions. What is hypertension?
Systolic blood pressure above 130 and diastolic above 80.
Okay, perfect. Whenever we have systolic more than, okay, what are some of the risk factors of hypertension?
Obesity, diabetes, a sedentary lifestyle.
Okay, perfect. Physical inactivity, having a lot of sodium diet. Whenever we have sodium diet, it can just like attract a lot of water towards itself, lot of blood within the effective circulatory volume, so it's going to be hypertension, right? So the features of hypertension, okay, it can also be due to unilateral renals. Yes, what's that condition? I want you guys to be telling me.
Renal arteries
Artery
stenosis as
stenosis.
well for chronic hypertension.
Okay, so can you guys tell me how can unilateral renal artery stenosis lead to hypertension? Yes, you guys have already did this topic.
A disease? Are you asking for a disease?
It can activate the RAS system.
Renin-angiotensin.
District release that leads to hypertension. Salt
Okay,
water and then
perfect, right? So on the imaging, whenever they tell you we have an individual with a lot of hypertension, even like the medication cannot improve that. But on imaging, we see one of the kidney was a little bit atrophic and other was fine. So what should you be thinking of?
For renal
Unilateral renal artery stenosis. So if you have stenosis here, the idea is really clear. Less delivery of blood, less delivery of NaCl to macula densa. We discussed it in detail, right? And whenever you have less delivery of NaCl to macula densa is going to send signals to your JG cells. It's going to make a lot of renin. Renin is going to activate your aldosterone in the end. Aldosterone would just, catch your Na. Water is going to follow that. A lot of water in effective circulatory volume is going to lead to hypertension. Is that clear? And on imaging, if we have like, a stenosed part here, so this, like due to less nutrient supply to this kidney, it would become a little bit atrophic, right? Small as compared to this normal one, right? So in this way, you can just diagnose this condition. Is that clear?
Yes.
You're going to see this MCQ on this concept again and again in a renal system, a lot of things, right? Just keep that in mind. Okay. Okay, so it was all about like appearance of atherosclerotic renal artery stenosis. So this can be due to an atherosclerotic plaque. It can be due to a condition that is fibromuscular dysplasia, right? That is string of beads appearance of renal artery. Like sometimes it can lead to stenosis, having a lot of fibrous content, right? We'll be discussing the fibromuscular dysplasia in detail, but you guys should know, right? Atherosclerosis can lead to the narrowing. So the concept is same. Whenever we have stenosis due to any cause, right? It can be atherosclerosis, it can be fibromuscular dysplasia, right? Then we have hypertensive urgency. What is hypertensive urgency?
It means elevation of the
180 or
hypertension
120.
without accuracy.
Greater than 180.
Hypertension without organ damage.
Perfect, without end organ damage. And if you have end organ damage, what's that called? Emergency. That's an emergency condition, right?
Yes.
Severe hypertension, for example, it can lead to. Okay, what does hypertension do to your small blood vessels? Which kind of necrosis?
It's fibrinoid necrosis.
Fibrinoid necrosis. Fibrinoid necrosis. We'll be discussing different types of necrosis. That is fibrinoid necrosis, caseous necrosis, liquefactive necrosis, coagulative necrosis. So one of the type of necrosis is fibrinoid necrosis, which is due to a lot of blood pressure or hypertension. Okay, so this was all about hypertension. and let's discuss atherosclerosis, right? So it's going to be our last topic. We already discussed traumatic aortic rupture in today's MCQ, right? That is, isthmus is going to be
Yes.
damaged in decelerating. Why? Because it's a fixed part surrounded by immobile part surrounded by mobile part, right? Which ligament hold this isthmus? What's the name of the ligament?
Ligamentum teres.
Ligamentum.
Ligamentum
Teres?
Arteriosum.
Okay, arteriosum. Perfect. Okay. Okay. Where do we have ligamentum teres?
That's in the liver.
Liver.
We will be discussing that in GI section. Okay. Okay. So then we have arteriolosclerosis. As the name indicate, arteriolos, small arterioles become sclerosed, thickened, right? It can be hyaline hyperplastic. What do you mean by hyaline? Whenever a lot of blood pressure leads to accumulation of hyaline, which is a kind of plasma protein, right? So plasma protein deposition can just thicken it, it can just narrow it, which is known as sclerosis, arteriolosclerosis. It can be hyperplastic, in which the medial layer is going to become hyperplastic, is going to lay down a lot of layers in a form of onion skin. Okay, where else do we see onion skin appearance? Let me just give you a clue. MSK.
Lungs.
It's Ewing sarcoma.
Having sarcoma.
Ewing
So
sarcoma.
in testis is the mass, the
Ewing sarcoma.
epiderm.
What else? Okay, so you are going to see onion skin appearance in a lot of systems, right? Keep that in mind. In cardiovascular, hyperplastic. Just the idea is simple. The middle layer is going to become hyperplastic in a form of layering pattern, right? Which is going to give you, like you're going to have an MCQ in your renal section, right? We have an individual, he died on a road, right? And after that, he was having an end organ damage. Biopsy revealed onion skin appearance. What do you think? What was the cause of death? Yes. What was the cause of death? Hypertension, right?
Yes.
Okay, perfect. Okay, so then you have atherosclerosis. So atherosclerosis is like a really simple one, right? Okay, atherosclerosis basically it have a lot of association, risk factor, right? Some are modifiable, some are non-modifiable. Who are going to be telling me the non-modifiable causes of your atherosclerosis?
Age, gender, menopause, family history.
Okay, and family. For example, if an
Post-menopause.
individual is having family history of atherosclerosis, and that is a dominant factor, let's suppose, in development of atherosclerosis in his later lives. So remember, he's going to have fatty streaks, right? What are fatty streaks? Very early in his life, even in 15 years of his life, 20 years of life, he can just start developing fatty streak, which are yellowish kind of, like that fatty deposition. Okay. Keep that in mind. You're going to have MCQs, a lot of MCQs on that as well. Fatty streaks start developing at a very early age of life. Okay, so like you can get an MCQ on your NBME. We were having a child, she died, and we did a biopsy of a lot of vessels, and he was having some yellowish deposition in his coronary arteries. What do you think? What are they? They are fatty streaks. Okay.
Fatty streaks.
Okay, keep that in mind. So basically, the LDL increases, HDL decreases. Can you guys just tell me LDL is a good or HDL is good?
HDL is good.
HDL is good, right? Okay. So basically, what's the function of LDL? It's going to increase. It's going to bring like the lipids from the periphery into the blood vessels. Right? LDL is going to remove that. Okay. So that's why it's considered to be good. Okay. So first of all, we are going to be the first step in formation of atherosclerosis is endothelial damage. Keep that in mind. First step, you're going to have a lot of MCQ on that. Okay. They'll be asking you, what's the first step of development of atherosclerosis? Yes. What's the first step?
Endothelial damage.
So whenever we have endothelial damage, the subendothelial collagen is going to become exposed, right? And once it gets exposed, problem is going to be starting there, right? What would happen? First of all, the macrophages are going to go there. Macrophages, the LDL, they're going to make foam cells, right? Whenever the macrophages eat LDL, it's going to lead to formation of foam cells. So in your U world, basically you have a video, right, on atherosclerosis. Once, just do that video like at least 2 to 3 times, very high, right? And you're going to be having like almost 15 MCQs in your UWorld regarding this video. If you just watch this video, like don't look towards the explanation. Just look that video, make notes of that. It's going to help you a lot, right? So what would happen? Like the best resource for doing atherosclerosis is your UWorld video. Right? There is a hyperlink. You can just click that. You'll be having a video. That's a really perfect video. Okay. So endothelial damage. This is also going to be one of your MCQ. The first step is endothelial damage. Fatty streak is also going to be is going to lead to formation of fatty streak. Smooth muscles are going to become like, like smooth muscles are going to migrate there. It's going to form a fibrous cap, which is going to strengthen your atheroma, the plaque, right? And for example, if the plaque rupture, what would happen if the plaque get ruptured?
It get lodged somewhere.
It would just get lodged, and if let's suppose if it get lodged in it, okay, the thrombus get lodged. So which kind of MI are we going to see on ECG?
STEMI?
Elevation, depression.
Elevation.
Elevation. Keep that in mind, right? Okay, so what are the factors which leads to recruitment of your smooth muscle cell migration? That are platelets derived growth factors and your fibroblast growth factors. Really important. Okay, keep that in mind. Okay, like for example, how can this plaque get ruptured? We have a fibrous cap there. Again, the fibrous cap have collagen, right? So for example, if you have inflammation or matrix metalloprotease, it can degrade the collagen. It can rupture the atheroma, which can cause SC segment elevation myocardial infarction, right? Okay, and with time, it can also become calcified. So that was all about today's session. And like we discussed most of the things. Hope so things are clear. Do you guys have any questions?
No, doctor.
Okay. Thank you so much. And I'll be sharing the schedule now. Okay. So you're going to be having micro session. So let's have half an hour break. And then we're going to have a micro session. And I'll just share the task and go to your Discord and start practicing your MCQs by your own. Okay. Thank you so much. Thank you. Hope so you guys enjoyed. Thank you so much. And we are just according to the plan. Like we are giving you a lot of time. Like Dr. Moaz is, explaining everything really well. And we are also just, putting it in a lot of time. So please, you guys should, be like consistent with your task. That's all what we need from you guys. Okay. Like will be almost done with your cardiovascular. It's a big system, believe me, right? So tomorrow or day after tomorrow we'll be done with pathology and one day for physiology. So you guys are almost done with your cardiovascular. You guys can see like you only have the little topics remaining here. So you should be consistent with your task. We are also going to be having a boot camp session, revision session. Don't be worried, those who have missed, and do not miss any classes or sessions. We are going to revise as we mentioned in the beginning. So the last lecture of Dr. was not recorded. Can you please stop? Okay, that was the last lecture which I discussed today, right?
Yeah.
Okay.
Yeah. Yes.
Yes, Dr. Sabera, that was the last lecture which was not recorded. So I just discussed each and every point today in detail. Okay.
Okay, I didn't know what I missed. Okay. Thank you.
So that was the hypertension and aneurysm. Dr. Moss did. We did that, and yes. Okay.
Thank you so much. Thank you.
Okay. You're welcome, and have a nice day. Okay. Bye bye.
Thank you. Bye bye.